One. We are live now.
Hello, good evening, everyone. It's a great pleasure to welcome you all for this exciting webinar on breast cancer update. It's a pleasure to welcome Dr. Nikhil Ghadyalpatil, Senior Consultant, Medical and Hemato-Oncologist from Yashoda Cancer Institute, Hyderabad. Hello, good evening, Dr. Nikhil. The stage is all set and we request you to for your welcome and introduction, please. Over to you, sir.
Thank you, Mr. Mathur and team. At the outset, I would like to invite you all the faculty members, delegates, friends, colleagues, seniors, everyone, for this today's and tomorrow's academic extravaganza. It has been a challenging time for all of us for last couple of years. We continue to navigate and negotiate through various COVID curves in the last couple of years. Having said that, the resilience of the knowledge, especially in the field of oncology, has been quite stunning, and we continue to witness newer and newer advances in this field. Today's and tomorrow's meeting is a sincere update to really gather information in the field of breast cancer and the recent updates, something which has happened in the last year or so. There is a lot of exciting and fascinating data which is going to be presented, and I'm sure there will be a lot of interesting discussions to back the same abstracts. We have all this faculty, especially belong to the southern parts of India, so I would really like to welcome all of you. With me, my colleague Dr. Firdaus is also there. She's also going to master the ceremony all throughout. Couple of important announcements for all the faculty members to stick to their times. It is quite important so that we can finish on time and we can have our dinner on time. At the same time, if there are any questions, one can actually post in the chat box, and there are certain questions which can be actually be taken during the moderation part of it. And last but not the least, as we go through these 2 days of sessions, we are hoping that we are going to learn a lot in these 2 days, more so in about breast cancer. And again, when you talk about breast cancer as a medical oncologist, sometimes we are culprit only for discussing more about medical oncology. This has not been the case with today's meeting. We are going to discuss about medical radiation as well as surgical oncology, and I'm sure we will have will be much more knowledgeable and which will be much more wiser as we proceed through our next Monday. So with this, I stop here. I again welcome all of you for this today's meeting. And without further ado, let me invite Dr. Sachin to start his presentation.
Yeah. Give me 1 second. Can you see it?
Not as yet, Sachin. I think you need to share your screen once. You can try once more.
Yeah.
Yeah, go ahead.
Yeah. So at the outset, thank you, Nikhil, for this opportunity. And as you already told, it will be one of the great webinar to have what are the updates. Especially as a surgeon, we are little lagging behind about the updates and all, because we keep busy in operating in the operation theater. And these kind of opportunities are really helpful as to what is happening in the world, what are the new systems are coming there, and it's a very good platform to share our ideas and new knowledge. So thank you for that. And my topic is intelligent vacuum assisted biopsy to identify breast cancer patient with pathological complete response, that is T0N0 after surgery and after neoadjuvant systemic therapy for omission of breast and axillary surgery. As we all know that many cancers like rectal cancer and anal canal cancers, now after neoadjuvant chemo radiation, when there is a complete response, There are many studies which are showing that wait and watch policies till the disease recur. Should we go ahead with surgery or should we just wait and watch? So such kind of cases are coming across in colorectal malignancy often, quite often. But now, can we anticipate the same in the breast surgery? Can, after pathological complete response on imaging or clinical examination, can we wait and watch? So these are new frontiers which I'll explain and in next few slides. So as we all know, neoadjuvant chemotherapy now is a protocol for locally advanced breast cancer to convert inoperable tumors into operable, for downsizing and for breast conservative surgery, inflammatory breast cancer, and many times now triple negative cancers, and which are little unfavorable. When the patient requires adjuvant complete systemic therapy, we are now giving it upfront, completing all the cycles before surgery. And complete pathological response, now we are seeing almost 40 to 70% patients in our day-to-day practice. And this NACT also helps in rapid assessment of the efficacy of the chemotherapy drug. And also sometimes if it is not effective or it is resistant, we can stop in timely manner so that we can immediately start the other regimen or we can take up for surgery. The definition of complete pathological response: it is the absence of invasive tumor as well as in situ carcinoma in the breast as well as in the axillary nodes, so both primary as well as in the nodes. And what are the good predictors of good response? These are small tumors, high grade tumors, high proliferative rate, tumor necrosis, presence of tumor associated lymphocytes, and patients who have HER2 positive, triple negative, and luminal ARB. So these all they respond very well. Almost 40 to 60% we see complete pathological response. And this can be assessed by clinical examination. Also with imaging studies, either could be mammography or digital mammography or MRI, and pathological examination after the surgery for the pathological specimen. Now, what is VAB? It is vacuum assisted breast biopsy. Many breast surgeons, they are doing it for benign lesions like fibroadenomas or cystic disease, sometimes patients who don't want scar on the breast, young patients. So these kind of procedures, many breast surgeons, they are doing in benign cases, benign lumps. But now biopsies we are also doing for breast malignancy. So it is more recent technique with proven clinical value. It can be used under sonographic guidance, mammographic guidance, and MR guidance. And the indications are clustered microcalcification, palpable or non-palpable lesions, BIRAD 3 or 4 lesions. And it offers best possible histological sampling with the aid to avoid unnecessary operations. That's what we were talking about. And the complications are small, like bleeding or sometimes pain or sometimes hemorrhage and hematomas. So this is the breast biopsy gun. What is a VAB biopsy? There is a sampling chamber. This is a needle with lumen with vacuum, and this is the rod which rotates around its axis. And this is the sampling chamber, and pathological, the specimen collects here and it goes to the, we send it for pathology. So this is the gun. And the advantage of this VAB special gun over the core needle biopsy, what we are practicing daily, is the size of the gun is little bigger. The sample size is more. So nowadays we are doing so many studies, so many receptors, so many NGS. So we need more samples. So this helps quite good specimen can come on that, and it reduces the multiple punctures. Suppose with the core needle biopsy we want more sample, we need to puncture 3, 4, 5 times, which is little difficult, cumbersome, especially in young females. So these biopsy guns, VAB biopsy, is very useful for this. So overall PCR rates are, as we discussed, is around 50% in the breast as well as axilla, which can avoid unnecessary surgery. Initial attempts of elimination of surgery were there, but they were unsuccessful because of poor imaging techniques and poor imaging modalities of response assessment. Now, poor negative predictive value for pathological complete response. And that's why there were, even though we clinically or imaging wise, we thought it is clinical response, but it was not actually clinical pathological response. And that's why the recurrence rates were more. So use of these improved imaging techniques along with the extensive vacuum associated biopsy in a tumor is actually has shown way for the pathological complete response patient to avoid surgery. So this patient paper published in JCO.
Dr. Sachin, sir, sorry
Yeah.
to interrupt, but you need to conclude, sir.
Yeah. So this is, I'll come there directly. False negative rate and specificity we see. And this is the chart, which is important. So imaging after neoadjuvant chemotherapy, VAB alone, NST plus VAB plus patient criteria, and this is intelligent vacuum assisted biopsy. So you can see the false negative value is almost 0%, specificity is 40%, negative predictive value is 100%. So we know where we are going. That's why, and we can actually use this VAB technique with intelligent algorithm to exclude residual disease, wait and watch trials which are already going on in other cancers, but that we can also anticipate in breast cancer. And similarly, the omission of breast and axillary surgery can be a future for breast cancer. So thank you very much, Nikhil, and all the audience for the listening. There is a small video, 45 seconds, but maybe we'll share how we do the breast VAB biopsy. We can share it at the end if we have a time.
Okay, Dr. Taranum, are you there? You can take over.
Yes. Good evening, sir. Thank you, Sachin, sir.
Yeah.
Now moving on. Good evening, everyone. Thank you, sir, for delivering your talk. Now I request Dr. Edil Selvan, Consultant Surgical Oncology, Kovar Medical Center and Hospital, Coimbatore, to deliver the next talk. Can you please join us, sir?
Yeah.
Welcome, sir.
Yeah, sure. Hi. Just trying to share my screen for a minute. Yeah, a warm evening to one and all here. So yeah, I'm just presenting a paper which deals with the trends in the surgical resection for stage 4 breast cancer. Basically, this is an audit that was done from the National Cancer Database by a group of clinicians headed by Dr. Sasha from the University of California, San Diego. So the background just goes this way, that in the beginning of this century, there have been quite a lot of enthusiasm in with regards to treating the primary, even in metastatic breast cancers. And basically this comes from quite a lot of retrospective studies which showed favorable results with regards to treating the primary, even in this metastatic setting. They have shown favorable outcomes with regards to the disease specific and also the overall survival. And hence this was quite in vogue at that time. But as in the last decade, there have been few randomized controlled trials which have shown otherwise. They have failed to support this hypothesis. So I think there has been a phase out of this loco-regional therapy in this metastatic setting, and this is what has been studied in this particular article. So this is basically an audit, and this database involved de novo stage 4 breast cancer patients diagnosed from 2004 to 2017, and nearly about 87,000 patients were taken for this audit. And the patient details, the treatment details, the disease details, and also those who have received the palliative care, they were assessed in the audit. And the results goes this way. As you see the first figure, it shows the percentage of people who have undergone surgery in the de novo metastatic breast cancer setting. And as we can see clearly that there has been a slight decrease in the percentage of people who have undergone surgery probably in the last decade. But the decline has been quite considerable when we specifically see the group which is ERPR positive, the favorable hormonal profile, whereas the others not much change. The second figure, again, it just shows that the interval between the time of the systemic therapy and the surgery has vastly increased in the last decade. And again, this is another graph which shows quite a bit of widening with regards to having only systemic treatment and having loco-regional therapy and systemic treatment. mostly from 2010 onwards. And there has been a steady decline and a considerable decline in the use of loco-regional therapy to almost half of what it used to be before 2010. And also what this study has seen is that there has been quite a considerably low number of people who have been referred to the palliative care. So they've just concluded that there has been a decline in the rate of loco-regional therapy in the study period, and especially in the last decade. And they hypothesize that this might reflect the absence of evidence from the randomized control trials. And this has been taken up by the cancer consortiums, the cancer tumor board meetings before they were decisions were made in their clinics. And there has been significantly less involvement of palliative care in this particular setting. So my take is that when we talk about a metastatic breast cancer, this is definitely not a single entity. It's quite a heterogeneous group of disease. So heterogeneous in sense, the age factors, the patient factors, the disease factors, with regards to especially the disease biology. We commonly use the hormone receptor status and the HER2 status to know an indirect disease biology. And most importantly, in a metastatic setting, the volume of the disease, whether it's oligometastatic, polymetastatic, and also the location of the metastasis. This is very important because to a great extent, the outcome of these patients depends on these factors. So not only that, in the last decade or so, there has been significant improvement in the systemic treatment, the targeted therapy, the immunotherapy that's coming into play. So the outcomes have greatly changed. And as a result, we can definitely know that or expect that most of these patients, at least those who receive a palliative mastectomy, might actually avoid having a surgery done. But what did these randomized control trials show? There have been at least 4 randomized control trials which have looked into this specifically, and 3 were negative, 1 was positive. But most importantly, on the whole, when you see these randomized control trials, the numbers were pretty low, and there have been enough and more pitfalls. This is all like a complete heterogeneous group. They couldn't look into a specific subset of people who would benefit or who would not benefit. But the most important thing that when you see these randomized control trial is that none of these randomized control trial took into consideration whether they have addressed the metastatic lesion at the time of addressing the loco-regional therapy in this particular setting. And why is this important? This is important, especially in the current era, with the light of information that we have got from SABR Comet trial, which looked at the oligometastatic site. Although this was a phase 2 trial, this definitely showed a positive result with regards to treating the oligometastatic sites and the outcome. And if you ask me a question whether this is going to have some outcome in the breast cancer, the answer is we do not know. But then, yes, potentially we might. So I would say that there is a potential or a significant area of overlap between the treating the primary site and also treating the metastatic site with a loco-regional therapy, and it might influence the outcomes. And hence, when someone who's just sitting in front of me in my clinic, if they ask me whether I'm going to go ahead with a loco-regional therapy or not, it is not a one single answer. I would say that this is a personalized treatment decision that is to be made by a combined tumor board decision. And as any other situations, we need to look into considerations like, the volume of the disease, whether it's going to be an oligo or a polymetastatic. And we know that if it's going to be a polymetastatic, we are not very keen in treating someone with a curative intent. And what is the location of the disease? What is the number of disease? And more importantly, the tumor biology, what their hormone receptor status says, and what is the HER2 receptor status. And if they have received systemic therapy, or if they are going to start with systemic therapy, what is the response like? Are they responding, or are they developing new lesions? They are progressing. And from all these things, I think the most important thing is how feasible it is for us to address the primary and also address the radiotherapy. Address the metastatic sites by either surgery or by radiotherapy. So I would still say that introduction of systemic therapy or the evidence that's shown by randomized control trial has not completely taken a loco-regional therapy out of the treatment protocol. I would still say that probably there might be more evidence which might come across with the treatment of primary and also treatment of the metastatic site with radiation, where it might again come back into a play. But for today's scenario, I think it's going to be a personalized treatment decision and taking all these factors into consideration. Thank you.
Thank you so much, sir. Moving on, for the next talk, I invite Dr. Pragya Chigurpati, Oncoplastic Surgeon, AAG Hospital, Hyderabad, to deliver her talk. Welcome, ma'am.
Hi, everyone. Should I share the screen? Okay. Can you see this?
Yes, ma'am. Please move. Please make it fully screen.
Yeah. Hi, everyone. I'm Dr. Pragya Chigurpati. I'm a consultant breast surgeon from AIG Hospitals, Hyderabad. At the offset, I'd like to thank the organization for having me over here. We're going to be talking about an abstract, safety of conservative surgery with accelerated partial breast re-irradiation for isolated ipsilateral breast cancer recurrence, regardless of immunohistochemical subtype. It was a multi-center prospective study from Spain. So what do we know so far? Salvage mastectomy is the standard surgery for ipsilateral breast tumor recurrence. There have been a few studies which were comparing repeat breast conservation surgery versus salvage mastectomy in women with an ipsilateral breast tumor recurrence, but all these studies have shown contradictory results. The most recent study was the NRG Oncology at the RTOG 1014 phase 2 clinical trial, which showed that re-BCS is a suitable alternative to salvage mastectomy. But also there were other studies recently published in 2021, which showed that adjuvant radiotherapy and systemic therapy also influence the endpoints such as DFS and OS. However, at the end of the day, we should remember that the guidelines say any patient who underwent a breast conservation surgery with previous radiation should still undergo a salvage mastectomy with axillary lymph node staging if level 1 or 2 with axillary dissection was not previously done. So this study was a prospective study between 2014 and 2020, which had 35 patients who were selected for a second breast conservation surgery, that is a new lumpectomy with accelerated partial breast re-irradiation. This was studied in 3 university hospitals in Barcelona, Spain. The eligibility criteria were patients who had a recurrent lump, above the age of 50 years, more than 48 months from the primary local treatment, that is BCS and whole breast radiation, isolated ipsilateral breast tumor recurrence with no metastasis, no multicentric or multifocal tumor on an MRI, less than 2 centimeters in size, no primary major radiotherapy toxicity, and the breast volume to excision volume ratio was favorable for a repeat BCT with an acceptable cosmetic result, and obviously a signed informed consent. So the results of this study were, these were the patient characteristics. A few important things to point out are that most of the cases were grade 2. Most of them were ER positive, nearly 80%. 74.3% were HER2 negative, and 48.6% were less than 20% Ki67. You should also note that 73.3% were luminal A or B, which were HER2 negative, because they had a separate subgroup, which were luminal B and HER2 positive. At ipsilateral breast tumor recurrence, the median age was 65 years old. Median time to recurrence was 154 months. And in the previous slide, I forgot to show that the total number of recurrences in the same quadrant of 48.6 and different quadrants were 49.7. So, and the tumor recurrences, 5 patients were that of BCIS and 30 patients were that of invasive carcinoma. All the patients underwent a wide local excision with APBI, out of which 67 were intensely modulated RT, 27% were 3D CRT, and 6% were IOR, intraoperative radiotherapy. 3 patients were of TNBC type and they received chemotherapy. 5 patients were HER2 positive. All of them received chemotherapy, with an exception of 1 patient who did not receive chemotherapy. And in those patients who were ER positive, all of them received endocrine therapy. The results were that a median follow-up of 37 months, there were 4 relapses, that is 11.4%, with 1 second ipsilateral breast tumor recurrence and 3 metastatic recurrences, 2 of which were invasive, and those were ER positive and HER2 negative, and 1 was in situ. There were 2 non-breast cancer related deaths. The 5-year regional free survival was 82.4%. 5-year metastasis free survival was 84.6%. And 5-year overall survival was 93.3%. So the authors conclude that conservative management with breast conservation surgery and APBI for isolated breast tumor recurrence after a breast conservation surgery seems like a feasible technique and is an alternative to mastectomy in select patients. Second, local recurrences and overall survival are similar to rates described for a salvage mastectomy for isolated ipsilateral breast tumor recurrence. And in this particular patient cohort, the IHC subtypes tumors with poor prognosis, that is, HER2 positive and triple negative, did not show an increase in the local recurrence rate after a breast conservation surgery. My take is that in this study, obviously there were a predominant number of lower risk disease, that is more ER positive, HER2 negative patients with low Ki67, and they were low risk. So we should probably select patients with caution. There were a smaller number in this study to extrapolate any data, and similarly, even in the other studies. Radiation side effects were not mentioned in this study, which is extremely important. And RCT will not be possible in this setting because it's unethical to do so. With the current data that we have from multiple studies, a repeat BCS with APBI may be considered in a highly selective group of patients, that is those who are unifocal, small tumors, ER positive with more than 1 year of DFI. However, this should be a multi-tumor board discussion. And if you ask me what I would do, at this point, I would still go ahead with a salvage mastectomy if I were to have such a patient. Thank you.
Thank you, ma'am. Moving on, I would invite Dr. Satish Power, Associate Clinical Director and Head of the Department Surgical Oncology Care Hospitals, Hyderabad, to deliver the next talk. Welcome, sir.
Thank you. Can you see my slides?
Not yet, sir.
Dr. Satish, you need to share your screen. Yeah, go ahead.
Yeah. So the topic given to me is the patient-reported outcomes. That's the quality of life for the INSEMA study, that is the intergroup sentinel mama study. In this particularly, actually, they have looked at disease-specific survival as a primary outcome, and then as a secondary outcome is the quality of life that I've seen in the study. So all the previous studies, the NSABP B04 and IBCSG 1093 have shown a high local regional control rate even without axillary nodal dissection in a N0 axillary nodes. So now the sentinel lymph node biopsy is the standard of care, as you all know, and we are all been practicing it. So now the present scenario, or the ongoing trials are seeing at omitting the sentinel lymph node biopsy as well. So despite increasing evidence supporting the sentinel lymph node biopsy alone, axillary lymph node dissection remains part of the breast cancer treatment guidelines. So once patient in this particular study, they omitted all the mastectomies, they have only considered the breast conservation surgeries. So current approaches, including screening population, tumor biology, and more effective systemic therapy, emphasizes the need for ongoing re-evaluation of standard local therapy. So the quality of life considerations are the primary motivation for abandoning the sentinel lymph node biopsy as well. So whatever the sentinel lymph node biopsy itself was considered, thinking about the quality of life and better as the patients are surviving more longer with all the therapies that our colleague medical oncologists are offering to them. So we are supposed to think about a better quality of life henceforth. So in this particular study, they have taken close to 5,000 patients. They have taken all the good prognostic markers, as we have been discussing all throughout in these, previously, even Dr. Pragnya also discussed the good prognostic markers. So in this, again, T1, T2 tumors less than 5 centimeters, planned for breast conservation surgery, obviously who are fit for breast conservation surgery and postoperative irradiation. They have been randomized into no sentinel lymph node biopsy versus a sentinel lymph node biopsy of in the ratio of 1:4. That means no sentinel out of the fourth patient will be no sentinel lymph node biopsy. So after doing the sentinel lymph node biopsy, again they were categorized into three categories. One is sentinel lymph node biopsy negative or with a micro that is N1MI. And once the sentinel lymph node biopsy was positive, only 1 to 3 involved sentinel lymph nodes. Again, they were offered whether to go for sentinel lymph node biopsy alone, but they were subjected definitive for definitive radiation and versus axillary lymph node clearance. So this again went into 1:1 ratio. So this was the second randomization. Obviously, more than 4 nodes would go for axillary nodal clearance. So the primary objective of the study was to compare the invasive disease-specific survival after breast conservation surgery between no axillary surgery and sentinel lymph node biopsy. And secondary endpoints, again, to compare the disease-specific survival once you do a sentinel lymph node biopsy alone, or you randomize the patient into axillary nodal clearance. And the secondary objective was the quality of life. So this is the study taking into consideration only the quality of life. So obviously the first randomization we were talking about, so they've omitted all the mastectomies, those who have not given consents, and they have randomized into no sentinel lymph node biopsy and into sentinel lymph node biopsy, but by the ratio of 1:4. And these patients, again, the second randomization I was talking to you about was between sentinel lymph node biopsy alone and completing the axillary clearance. So the methods they have followed was the standard URCTC QLQ-C30. This is the standard quality of life questionnaire which they have been following, and they have each patient was asked the same questionnaire at 1 month, 3 months, 6 months, 12 months, and 18 months. And higher scores of C30 and BR23 was to the range of more towards the range of 100, and they indicate better functioning and global health status or worse symptom severity respectively. So and then score difference of more than 5 was considered as clinically meaningful difference. The quality of life scores were analyzed using repeated measures of mixed effects models leading to p-values of treatment and time, and for the interaction time by time. So postoperative whole breast radiation was mandatory for all patients. So that's why this study only considered for breast conservation surgery followed by whole breast irradiation, and if, the partial breast irradiation also omitted, and ipsilateral axillary lymph nodes were not included in the clinical target volume. So this is a point to remember, that they have not included the ipsilateral axillary region to for radiation therapy. So again, you have seen that whatever the good prognostic factors, T size, and grade 1, grade 2, and ERPR positive, all these were more in number in both the first randomization as well as in the second randomization. And in the first randomization, the people who could complete the questionnaire also were more than 60%. So that was a good point, because to give a good quality of life analysis or an assessment that can be used in this. So as I was talking about first month to 18 months, they have seen the the questionnaire, and they were seeing better results. So in this particular, obviously the arm symptoms and the axillary symptoms were lesser in no sentinel lymph node biopsy versus in as compared to the sentinel lymph node biopsy group. That was obvious. And when you compare both the axillary versus the sentinel lymph node biopsy, obviously the sentinel lymph node biopsy fared better. So in this particular study is one of the first randomized trials investigating the omission of sentinel lymph node biopsy. That means not touching the axilla at all in clinically no negative patients, and the first to report the quality of life data. So you have to be very, very careful in selecting these cases, and you have to be doubly sure that the node is negative by doing the ultrasound and doing the FNAC and proving it that there is the axilla is not invaded at all. So patients with no sentinel lymph node biopsy had improved breast and arm symptoms compared to those with sentinel lymph node biopsy. Patients in the sentinel lymph node biopsy group had improved arm symptoms and functioning compared to those receiving in the completion axillary lymph node clearance. This is the second randomization. So no relevant differences in other quality of life scales are seen. So invasive disease-specific survival, that is a primary outcome, are expected to be shown by the end of 2024. So this is still an abstract only has been released, and only the quality of life data has been shared because they have completed, all the patients have completed 18 months of treatment. So follow-up is ongoing, but this is a food for thought for all of us, where complete when there is a post NACT after complete response, there's a very good response, and the complete the primary has disappeared, omitting that by doing repeated biopsies. This is another food for thought, where N0 axillas we can straight away omit, because axilla is a staging procedure. Thank you very much.
Thank you so much, sir. Moving on, we'll have a panel discussion for the abstracts we have discussed till now. For that, I request Dr. Prashant Penumadu, Additional Professor, Department of Surgical Oncology, JIPMER, Puducherry, to join us as a moderator for the panel discussion. And I invite our panelists, Dr. Arvind Krishnamurthy, Professor, Surgical Oncology, Adyar Cancer Center, Dr. Asha Reddy, Consultant, Surgical Oncologist, Chennai Breast Center, Dr. Sachin Mata, Senior Consultant, Surgical Oncology, Yashoda Hospital, Hyderabad, to join us for the discussion. Welcome, sir.
Before you start, Prashant, I also request all the speakers to be around in case there are certain burning questions. Thank you.
Yeah, hi. Am I audible?
Yes, Dr. Prashant, go ahead.
Yeah. Thank you, Dr. Nikhil and the entire organizing team for giving me this opportunity. So I think we have gone through the abstracts in detail and without wasting much time. So the topic is, what would you do on a Monday morning? So it's predominantly what the experts would do is what I understand. So I think I have all my panelists here. Dr. Arvind, Dr. Asha, would you mind switching on your cameras? Dr. Sachin, Dr. Pragnya. Thank you, sir. Thank you very much. So now without wasting much time, we have 20 minutes and we'll try to cover as much as possible. So we'll be going through the first abstract. It's about an intelligent vacuum assisted biopsies to identify breast cancer patients with pathological complete response after neoadjuvant for omission of breast and axillary surgery. So I think this is something which I would call it ambitious right now today. So experts. Dr. Arvind, sir, how would you manage a complete clinical response post neoadjuvant chemotherapy at your center as of now?
Thanks, Prashant, and thanks for the organizers to having me. I think with regards specifically to this question, I think the decision for management of the breast or axilla, I feel, should be made upfront, essentially, that is the more important thing. And if especially you're giving neoadjuvant therapy, you have to sort of map the tumor and possibly also, if possible, the axilla. So there has to be sort of a marking, whatever way you do it, for the tumor and the axilla, and the management ultimately would depend upon the response to the neoadjuvant therapies. And then we will sort of know. So to put it in short, I think we would sort of tag the tumor. And of course, for lymph nodes, I know that theoretically people are tagging, but right now we are not using any sort of tags for the lymph node. But definitely, yes, the tumor will sort of be tagged, and based on the response, we would take the decision for surgery.
Yeah, thank you, sir. At a very important point, rightly mentioned by Dr. Arvind, sir, is you take the decision before. And you mark your lesion well in advance, even before you initiate, so that your decision making later on would be whatever possible. So Dr. Asha, do you agree or do you do something different?
Yes, Dr. Prashant, same thing. So I think marking the lesion and then deciding based on how the presentation initially was, whether a conservation or a mastectomy is indicated.
Okay, thank you. A question to Dr. Sachin, what are the challenges faced while considering breast conservation in such scenarios when you have a complete response? Let's say that you have marked a clip, you've placed a clip in the neoadjuvant setting, and then, what are the challenges that you commonly face?
Normally, after very good response clinically with this neoadjuvant therapy, it's intraoperatively, we have to think what the pre-op, and as you already told, when there's a clip, initially remove as a standard procedure, breast lumpectomy with the clip intact, and also intraoperatively also we takes help of the radiologist to get some extra margins. And also sometimes there is the response would be fragmented. Sometimes there are some areas of fibrosis, so we include little more and send it for frozen section. Sometimes the response could be like microscopic disease. I have to again revise and send it again. Yeah.
Okay. Yeah. So any particular, Dr. Arvind, like, I mean, have you faced that you could not identify the clip sometimes? I mean, I have faced that, so I didn't know what to do. So what's your experience?
Yeah, I think, yeah, there will be challenges, of course, if you place it, but it's very important also to sort of, decide on how you make the response assessment. Of course, it has to be clinical as well as radiological. And we sort of, do only the traditional imaging in the form of either definitely a mammogram or sort of an ultrasound only. If for some reason you've done an MRI, then possibly you would again do an MRI. But I think the use of MRI is only far and few in our setup. And the most important tip I can tell you is that possibly image just closer to the day or two prior to the surgery, because you can have sometimes clips migrating or they not being there and all those things. So we have had one or two occasions in which we have had surprises like your thing, and then subsequently what we decided as a protocol was to do some sort of an imaging just prior to the day of surgery, and then you assess once again the response, and then you decide, of course there are very many ways of doing it. Some people use frozen sections, some people use intraoperative ultrasound, some people use cavity shavings and all those things. So of course ultimately it's your clinical discretion based on the response, how it is on the radiological and intraoperative judgment.
Thank you, sir. You have partly answered my next question on the imaging modalities. So, Dr. Asha, would you routinely get an MRI in all these patients? Because Dr. Sachin was mentioning about fragmented response, which is of a concern. So, what is your imaging modality of choice?
Practically, we're still using mammogram and ultrasound most of the time. If there's any challenges in the mammogram or if an MRI was done previously, like Dr. Arvind mentioned, then we can always follow up with an MRI post NACT, but it's still not being done for every case.
Okay, thank you. So we still follow the imaging. Why I'm telling you in this context, why I've reiterated Dr. Sachin's words is, fragmented response. We're not very sure. So we don't have an ideal imaging modality to actually predict complete response. And I think this algorithm is something which can actually predict a good response. And if you can see, the false negative rate is 0%, which is very impressive. So, which is really impressive. And if it is 0%, are you all ready to observe the axilla? So we'll start with Dr. Pragnya. I hope she's there with us. Breast and axilla, Dr. Pragnya.
Yeah, hi. Sorry, could you just repeat the question again, please?
Yeah, so knowing that the false negative rate of this algorithm is 0%.
Yeah.
Okay, so are you ready today to observe the breast and axilla?
No, honestly, I don't think I am. I would still go ahead with surgical excision because we don't have any data regarding using this algorithm, and just imaging wise, it does not mean it's pathological complete response. So probably not.
No, this abstract is very interesting in the sense that they have actually done an imaging and then correlated with final histopathology after surgery, and they have said that the false negative rate is 0%.
This is not level 1 evidence.
Yeah, they have, yes, evidence. This is evidence based. So
I would not go ahead with it based on this.
Okay. Yeah, Dr. Arvind, I think Dr. Sachin has presented the abstract, and so I'll take his opinion at the last.
No, I feel it's a promising thing, especially that this is not just regular web, this is intelligent web. So there is some component of artificial intelligence also in it. So I'm pretty excited about this technology, considering the FNR of about 0%. But as was said, no, we would wait for a proper validation study before we actually take it up in regular practice. But I think this is something food for thought. I think this is coming not just in breast, but many other solid tumors. And I feel that maybe breast would be one of the subsites in which I guess the omission of surgery may possibly come first. So I think we should closely follow the space and get acclimatized to this technology and prepare ourselves in the eventuality that at some point of time, maybe it may take many years, but at some point of time, when, if at all the evidence comes, we are up and about for the same.
As you rightly said, they're preparing us for non-surgical management, sir. So we need to, they're making us more jobless. So, but I think it's a good food for thought. And this is just to brief about the evidence so far. We know that there's a randomized control trial, which actually showed that surgery versus no surgery for those patients. The loco-regional recurrence rates has actually been higher in the non-surgical group. But however, very important point to note is incomplete responders with whatever available imaging. There was no difference in loco-regional recurrence. So probably this is what the current study is also trying to look at, improve ways to find out that there is complete response and then take it forward. And there's another ongoing Mirka study, which I would go with it. Without wasting much time, Dr. Sachin, I'll come back to you for the next two things. I'm sorry, in the interest of time. Yeah, so the second abstract, trends in surgical resections, Dr. Elil actually did a wonderful presentation bringing us the data. There has been a drastic decline in the number of mastectomies or loco-regional therapy that's actually going on, but he also brought out very interesting points from his aspects where the metastatic lesions are not addressed. So you have just done a loco-regional treatment, but not addressed the metastatic lesions irrespective of those being oligometastatic or multimetastatic. So expert's opinion. Yeah, I'll start with Dr. Asha. How do you manage an oligometastatic breast cancer at your setting post 2013 after the result, after the RCT was published?
So as of now, the oligometastatic breast cancer, we usually start with systemic therapy and looking at many considerations as to the site of the metastatic site, the biology of the tumor. And if it's usually a single metastatic site, one or two more restricted to the bone, then we do look for loco-regional therapy in terms of surgery and treating the oligometastatic site.
Okay, so this is how you would treat the entire disease, not just loco-regional alone, whenever possible and feasible.
Whenever
Dr. Sachin, you agree? You agree with her? Is that same?
Yes, definitely. We have a lot of patients which have only one or two lesions, especially in maybe in the bone or maybe chest wall or maybe some liver lesion, and definitely local treatment, surgical treatment, and with ongoing chemotherapy, systemic treatment we are following. We have good number of patients along with Dr. Nikhil.
Okay, yeah. Arvind sir, any change of opinion or would you go with the same?
Practically the same things, but then we'll have to make a distinction, as to what exactly you mean by oligometastasis. That itself is a sort of, a heterogeneous sort of a group. It could be like somebody said, like, one single site in which our approach would possibly be inclined more for the curative intent. And some of these cases were not included in the Indian randomized control trial by Dr. Badwe. Of course, it was included in other subsites. So we'll have to make that distinction. And as for now, considering our philosophy, maybe if there is a single subsite, then we would possibly treat that as with a potentially curative intent, and always sort of, try to have loco-regional treatments, both for the primary as well as the metastatic site. But then again, as I said, just in the interest of time, I would probably be a little quick. In the other sites, like more than one, say multiple sites or polymetastatic, as you would call, then as Dr. Asha said, that it will be based on the response for your systemic therapy. Then you would take the call as to what needs to be done. And again, I would also agree with the broader trend. We are not doing regularly mastectomies unless it is required for a palliative intent in the scenario of a polymetastatic breast cancer, irrespective of the immuno.
Agree, sir. Agree. I mean, actually, in multi-metastatic, I think the evidence clearly says, and then we do not. I was actually hoping that at least one of the panelists would say that no, we wouldn't do based on RCT. So that's why I put the second question. So it goes null and void right now. So we know that there is no enough evidence. So, and the third interesting thing which was raised is the palliative care services across, even in a center where palliative services are, available for the patients, are very low. So yeah, I'll take this question to Dr. Pregna. What's your opinion? How do you see for metastatic breast cancer, how frequently do you send your patients to palliative care?
Well, most of the patients, if we do know that we wouldn't, it's with the intent is clear that it is only palliative, we do refer most of the patients for palliative care. And but obviously a thorough amount of counseling is extremely important to the patient. And they have to understand that there is no cure at this point in time, and systemic therapy is the way to go. So, and thankfully we do have a department that caters to their needs. But so at that point, we would focus on quality of life as well. And like I mentioned, it's important that the patient knows what the treatment is all about.
Okay, thank you. So I think palliative care is something that which we should all look at sending our patients early. I know that there is a paucity of palliative care centers across the country, and it really makes a lot of difference. So yes, so to conclude on this, as of now, oligometastatic, we do not have adequate evidence to actually rule out treatment with curative intent. So it has to be a multidisciplinary tumor board. But at the same time, the number of mastectomies or the loco-regional treatment has gone down drastically following evidences post 2012-13. And I think it's good that we are going evidence-based rather than just by expert-based. Yeah. So now coming on to the next abstract, an interesting abstract following in IBTR. Patients were treated with breast conservation and re-irradiation. Dr. Sachin, your take on this? I mean, Dr. Pregna presented very well the population, the group of population are low burden tumors, less than 2 centimeters. I think probably these are the tumors you would select for an APBI too. Yeah. As far as the evidence is there, we can, but when the patient already underwent 1 or 2 surgeries, followed by chemotherapy, radiation, and then if there is again recurrence, many times, even though we tell them it would be very, very difficult, because recently I had operated one lawyer who had the same issue. In spite of counseling, it was very difficult, very difficult. So as of now, probably we can tell them, but at the end of the day, they will go ahead with the mastectomy. Okay. Dr. Pregna raised out very valid points for this trial, that the numbers are small and it may not be possible to do an randomized controlled trial. So, and I don't think it would be practically possible to get such kind of tumors and even get this data in the next 10 years. So, Dr. Asha, are we going to offer salvage mastectomy for those patients in the inclusion criteria, or wait for another 10 years for evidence?
I think for most, it's going to be a mastectomy, but possibly the elderly, hormone positive, good biology, far away from the primary, with the longer DFI and the radiation oncologists are comfortable re-irradiating. Maybe the one-off, cases can be highly selected for this, because I don't think we're going to get much more data on this with higher numbers or RCT wise. Not for everyone, but the highly selected cases. Yeah.
I think it has to be an informed choice. And from the radiation perspective, if I can ask some of our radiation oncologists in the faculty group, how comfortable are you re-radiating with APBI following a breast conservation surgery? Any of the radiation oncologists? Doctor?
Hi, can you hear me? This is Dr. Nandita.
Yeah, hi, Dr. Nandita, please.
Hi. So I'm a radiation oncologist from AIG. So in terms of re-radiation for breast, I think if you see the long-term toxicities of breast, you need at least 5 years of follow-up to actually say what the long-term toxicities are, because most of it they revolve around the breast cosmesis in terms of induration, telangiectasia, and fibrosis. So you can do this now, but at the end of 5 years, if you end up with a breast that looks like a shriveled up prune, it's absolutely of no use. So I think the 5-year or even longer toxicity results is what will actually make the difference. But considering that APBI obviously involves a smaller volume of radiotherapy, so I think once the 5-year results are out, we until they're out, we can't really disregard or consider this as standard of care at this point.
Sir, sorry for intervening. We have 2 minutes left to complete.
Yes. Last few slides. So it has to be information. I agree, we're not going to get much more evidence on this, but then interesting results and interesting study to look up on, because the second IBTR was only 2.85% with a good 5-year regional free as well as metastasis free survival and overall survival too. So yes, now coming on to the last study presented by Dr. Satish, patient reported outcomes. This is an interesting, we all know that definitely the quality of life will be better if you don't touch the axilla. It will be better if you do a sentinel lymph node biopsy when compared to axillary lymph node biopsy. But I think this is the first of its kind study to have actually published the quality of life, this thing. So yeah, these are the same results and data that has been. So what's your current practice right now, Dr. Arvind, if I may ask you, completion or radiotherapy for the axilla for 1 to 3 nodes positive?
Somehow we don't classify as 1 to 3, like anything if it is fitting into the ACASOG Z11, only then we would sort of know. So because in ACASOG Z11 it was 2 or more. So I guess that has been our trend also. And somehow we don't follow the AMARA sort of a protocol, is something somehow our institution doesn't seem to follow. But then if it is falling in the ACASOG Z11 criteria, that is the 5 criteria that's there, not going in the interest of time, then possibly we are comfortable not completing the axilla for these patients. But otherwise, if it is 3 nodes, I think our tendency would be to complete the axilla. Or if there is any criteria which is outside the ACASOG Z11 criteria, we would sort of complete the axilla.
Okay. Yeah, Dr. Asha, this is our last slide. So we just, Dr. Asha, your opinion on what do you practice at your center?
We do follow the AMAROS, especially with the 10-year update. I think it's something that we should work towards, and that's something that we are doing. So 1 to 3 nodes, we are radiating the axilla and avoiding a complete clearance.
Okay. Dr. Sachin?
We are completing axilla.
We're completing axilla as of now. Yeah. Dr. Satish, I think, is he there with us? Yeah.
We are still okay with especially with the 2 mm and capsular metastasis, micrometastasis. We are more comfortable omitting the axilla. More than 2 nodes, obviously, we are, of the fear that more number of nodes will be involved. So we are not comfortable, leaving behind the disease like that. So we are erring on the axillary nodal clearance at this point.
Yeah. I think till the results come, we are still not erring. So I think we may be right or we do not know actually. Yeah, Dr. Pragya, any change and any difference in opinion?
No, like Dr. Arvind said, we do, in selective patients, we're going ahead with clearance. And again, based on, it completely depends also on the biology, but then we do go according to current guidelines of clearing the axilla. But AMAROS is something we should look into.
Okay, great. So last question for what are the challenges faced with SNB and acceptance from patient perspective, as well as from physician's perspective? Last say from all the experts. Dr. Arvind, to start off with.
I think sentinel lymph node is something that we should offer patients. Sometimes the challenge would be conservation versus mastectomy. Sometimes I think it all depends upon institutional practices and all those things. But I feel sentinel is something that, there is strong data which has been there over the years. I think we should start giving it. Of course, there are some issues with offering sentinel node post neoadjuvant chemotherapy. So you really need to be a good center, harvest good nodes, do dual positivity, if at all, tag the nodes and also. So there may be certain challenges in offering sentinel node in the post NACT setting, but upfront sentinel node, I think it's a mandate to offer it to all our patients, and that's my small brief take on this.
Agree, sir. Dr. Asha, any challenges that you come across from patient's perspective?
Usually not so many. I think it's more the technique and availability of, the dye and technetium, or, even if a single dye is possible, I think sentinel, especially in the upfront setting, like Dr. Arvind said, should be offered. And not many challenges from the patient side, for sure.
Okay, thank you. Dr. Sachin?
Yeah, they do agree. When we give option of sentinel node biopsy, they do agree and they tell us to go ahead with SLNB. Yeah.
Okay. Yeah, Dr. Pragnya.
Not much of a change. Acceptance from patients' perspective is basically whatever we tell them. So we have to make sure that we offer sentinel node or a low axillary sampling, even if sentinel node is not available. So hopefully surgeons are trained in them and counsel the patients regarding what the procedures that are actually available and go ahead with treatment. Because if you say it's a node which is clinically positive or there are nodes and we'll be clearing it, they will accept it, unfortunately, because they don't know what the other options are. So I think it's very important to counsel them the right way.
Yeah, so I think thank you very much. Sentinel lymph node biopsy is here to stay, and we should find all ways to actually reduce the trauma to the axilla so that the patient reported outcomes and quality of life will be much better. And thank you. If there are any questions from in the chat box, our panelists would be happy to take them, or else we will call it a day. Thank you very much. I thank all my panelists for the wonderful discussion today. Thank you.
Thank you.
For our first session, thank you all the faculty members for their valuable insights. Now we move on to our next session regarding hormone receptor positive early breast cancer. I invite Dr. C.S. Ghadyalpatil, Chief Medical Oncologist, Lenovo Soumya Hospital, Hyderabad, to deliver the next talk. Welcome, sir.
Thank you so much. Thank you so much, Nikhil and Tarun, for making me a part of this CME. And I will talk about palbociclib effectiveness data. It was in Feb 2015, 6 years back, when palbociclib got its first approval in the arena of ER-positive, HER2-negative metastatic breast cancer. We have the Globocon 2018 data. Can I have the slides? And we know that breast cancer ranks second in incidence. The next slide and the next slide. Some disclaimers is the next slide. Yeah, Globocon 2018 data. Breast cancer is second in incidence and fifth in mortality. Next slide. Globocon 2018 India data. It ranks number 1 in cancer incidence. Next slide. Coming to the MBC landscape, I think all of us know that around 60% of the MBC breast cancers are ER positive and HER2 negative. A third of patients who are having early disease will develop or recur with advanced or metastatic disease, and less than 10% of patients are de novo MBC. And next slide, the spectrum, as we all know, ranges from virulent MBC to an indolent MBC. Next slide. Retinoblastoma gene product is active when it is hyperphosphorylated. And so, next slide, cyclin D and CDK4/6 come together to make sure that you phosphorylate that, and that leads to the gene transcription happening. And so if you have a CDK4/6 inhibitor, then you would be able to regulate the G1S entry. Next slide. Palbociclib was such a first-in-class CDK4/6 inhibitor, which was able to prevent cell cycle progression from G1 to S phase because it was able to block the phosphorylation of the RB gene product at very low nanomole concentrations, be it cell lines, cultured cancer cells, or xenografted cancer cells. Next slide. And so we have now the update indication of palbociclib. As we all know, palbociclib plus an AI or fulvestrant is used in HR positive, HER2 negative, LABC or metastatic breast cancer. Next slide. Look, not looking at multiple global phase 3 trials, but I will just give a brief intro about the global phase 3 trial Paloma 2. For 666 patients randomized 2:1 to palbociclib letrozole versus letrozole plus placebo. Next slide. And those are the demographics and baseline features. Median is 60 years, ECOG PS 0 or 1, more than 98% of patients. Almost 50% of patients had visceral disease, and around 20% of patients had 4 or more than 4 disease sites. The DFI from the last hormone treatment was less than 12 months in 20 months, and in 20% and more than 12 months in 40% of patients. Next slide. We'll talk about the update, which gives a follow-up of 37 months. telling that the PFS in the investigator-assessed intent to treat population is 27.6 months. Now that's almost double of letrozole alone, which is around 14.5 months. So the median PFS of palbociclib and letrozole combination as first-line treatment is 27.6 months with a hazard ratio of 0.56. The p-value is highly significant. So I think we'll recollect these two figures and remember them. Median PFS 27.6 months and hazard ratio of 0.56. Now we may think that patients with visceral disease tend to benefit, but patients with non-visceral disease or bone-only disease also tend to equally benefit by adding palbociclib. You may think that the TFI is more than 5 years or more than 10 years. Maybe we can think of using single and letrozole, but no, whatever the TFI, the combination of palbo and letrozole is far better than letrozole alone. And age less than 65, more than 65, adding one more molecule, letrozole, doesn't come in the way. Next slide. To look at the PFS in two subgroups, bone-only disease or single disease site, I think the curves speak for itself. Palbociclib plus letrozole clearly overscores over letrozole alone. Next slide. 85% of patients have clinical benefit rate, be it the all randomized patients or patients having measurable disease. Now, around 40 to 55% of patients have an overall response or a partial response, and very few are complete responses. Whether it's a complete response or a partial response or a stable disease, whatever be, as long as this is controlled by adding palbo to letrozole, the median duration of response is in excess of 20 months and it's around 2 years. So what that tells you is that your patients may be complete responders or partial responses, or it could be just stable disease. All these patients, the median duration of response is around 2 years. And so you don't have to get bothered if your patient doesn't get a response or a complete response. As long as it is stable disease and is controlled, the median duration of response or otherwise remains around 24 months or 28 months. What's important is that the first-line combination of palbo and letrozole is able to make sure that the first subsequent chemotherapy is prolonged. Next slide. And in fact, the median event-free survival is 40.4 months. So it's only after 40 months that the patient ends up getting the first cycle of chemotherapy. So the conclusion of the Paloma 2 phase 3 trial is, next slide, this is an important first-line therapy option. With 37 months of follow-up, the median PFS is 27.6 months, clinical benefit rate of 85%, no new safety signals, and the incidence of febrile neutropenia is hardly 2%. With that background and a hazard ratio of 0.56, we now come on to some real-world evidence studies and look at some global data and then some Indian data too. Next slide. So IRIS, Flatiron, Polaris, and the Expanded Access Program are some of the select real-world studies. As I told you, in Feb 2015, the first approval happened, and now after 6 years, we are today in Feb 2022 talking about the some of these real-world data when compared to the phase 3 trial. Looking at a few of them, IRIS study. Next slide. Retrospective chart review. This is not the CML IRIS. This is, next slide, IBRAN's real-world insight studies from USA and Europe. At 24 months, the PFS rates and the OS rates, whether it's USA or Europe, are almost similar in excess of 60% and 90%. And the clinical benefit is in excess of 90%, whichever the continent or the study sites. Next slide. And the same is also true for palbociclib and fulvestrant. The 12-month data of IRIS USA and Europe is almost similar with regard to the PFS and the OS. The clinical benefit rate with the palbo-fulvestrant combination is more than 85%. The conclusion of IRIS, therefore, is, next slide, a high proportion of patients started on palbo 125 mg per day. So you don't have to worry about starting at 75 or 100. You can start your patients on in cycle 1 itself at 125 mg per day. low rates of dose reduction. Of course, we spoke about 12-month and 24-month landmarks, but ongoing studies can give even more mature clinical outcome data. So that's my conclusion, the IRIS study. Next slide. Kind of the Flatiron data. Next slide. So that's the USA Flatiron network of more than 2.2 million active patients. Electronic health records of HR positive, HER2 negative MBC patient analyzed. Next slide. Total population 772 versus 658, palbo-letrozole versus letrozole alone. And when you look at the propensity score matched cohorts, the number comes down to 464. Next slide. The real world PFS and OS. Real world PFS is around 20 months versus 12 months with letrozole alone. Next slide. After the propensity score matching, the median PFS comes in at 20.2 months. I did tell you that the duration of response with palbo-letrozole PALOMA-3 also was 20.2 months. Next slide. Whatever the subgroup you take, all subgroups in this real-world Flatiron data stand to benefit by adding palbociclib to letrozole. One diamond there is to the right favoring letrozole, but then that's something like a data of 199 patients and where the race was others or unknown. So I think we should disregard that. The conclusion of the Flatiron is, next slide, in this population which was heterogeneous, palbociclib letro is more effective than letrozole alone. PALOMA-3 hazard ratio was 0.56, and here also hazard ratio is 0.58 for PFS and 0.54 for the overall survival. So therefore, this data complements the data of PALOMA-3. Next slide. But then what about the patient-reported outcomes? Because we realize that neutropenia can be a worrisome side effect for the patients. Look at the report. But we all know it's a paper side effect. And evaluation of the PROs in the Medline study tells us that there's no relation of neutropenia and it hampering the quality of life. This being, next slide, 45% of patients experience neutropenia, and the low level of pain and fatigue also does not change or is not correlating with the neutropenia experience. So neutropenia, or yes or not, a low level of pain or fatigue can happen, and neutropenia is not the cause for that. Now, what about treatment satisfaction survey? Next slide. Now, this was a web-based survey from USA, Canada, Germany, almost 6 countries. Next slide. And they looked at 604 patients. Next. To look at 3 important questionnaires: therapy expectations, feeling of the patient about side effects, and satisfaction with therapy. Next slide. More than 90%, the side effects were as expected. More than 75%, the treatment helped return them back to a normal life. Side effects were not a deterrent. And more than 95% felt that they were with the therapy satisfied. Next slide. So with that, we now come to some Indian data. Next slide. Chennai Adyar Cancer Institute, 18 patients. The median PFS was 18 months by using palbociclib. Next slide. And therefore, they said that the PALOMA-2 trial was more than 24 months. Their PFS of 18 months, so the real-world outcome can be or is inferior in that study of 18 patients. But I'll show you 2 more studies of larger number of patients. Next slide. Now, this was a multi-center study from 5 centers in South India with Amit Rauthan as the lead author, 133 patients. Next slide. And be it as first line or second line, they found out that the efficacy and safety is similar as they saw in the PALOMA trial. So the Indian data seems to corroborate with the global data, with the randomized phase 3 trial data. Next slide. Yet another study from the Rajiv Gandhi Cancer Center and the BLK hospitals from Delhi of 188 patients. Again, next slide. As first-line treatment or second-line treatment, palbo-based combinations give similar effectiveness, which is what we have seen with the other previously published real-world evidences. So let's look at some Indian practical consensus recommendations. Next slide. By Sendil Rajappa et al. Palbociclib and AI combination can be the preferred first-line hormone therapy. and a combination of fulvestrant palbociclib should be offered to patients who have progressed on an AI alone as the first-line treatment. So to conclude, next slide. In my opinion, palbociclib has changed the treatment paradigm. Before 2015, you did not have any new treatment options, and AIs were ruling the chart. But the data, the real-world data I presented clearly tells us that the median PFS is more than 2 years. Real-world data supplements and complements the randomized control trial data. The quality of life is maintained even with longer treatment duration. Your patient now is on treatment combo for more than 2 years, 28 months median PFS, and still the patients rate the treatment satisfaction as with very high scores. The final word, palbociclib represents a significant advance in the care of HR-positive, HER2-negative MBC, first-line treatment with manageable adverse events. Despite neutropenia, that's a paper side effect, the quality of life is preserved or better for most of the patients, and the use of chemotherapy is deferred to more than 40 months. Thank you so much, Nikhil, and all the audience for being a patient throughout the last 20 minutes.
Thank you so much, sir. If there are any queries are welcome. Please raise your queries in the chat box.
So before we take any questions, thank you, Dr. Dattatreya, for your wonderful presentation as always. One question we keep on asking all the time, and sometimes the patient also keep on asking, which CDK4/6 inhibitor? So how do you normally counsel the patient, and how do you normally go for that one particular drug over the other?
I would like to be honest about my practice. So whenever I find poor prognostic subgroups, which as per the ABEMA trials has been like, say, PR negative or a liver metastasis, visceral disease, I tilt towards abemaciclib. Rest all patients, I would possibly rate ribociclib, palbociclib, and ABEMA on the same platform. Having said that, I have nothing against any of the other two CDK4 inhibitors, but I'm okay with all of them.
Thank you so much. Thank you. Thank you for your valuable insights. I think over to Dr. Firdaus for the further masters.
Thank you, Nikhil. Thanks a lot.
Bye.
Thank you, sir. Moving on. Before moving on, I would like to mention that this session is being sponsored by Pfizer. For the next talk, we have Dr. Aditya Murli, Consultant Medical Oncologist, Aster Hospital, Bangalore. I request him to join us for the next talk. Thank you, sir. Welcome.
Thanks, Dr. Firdaus. Can I please ask the organizers to pull up my slide set, please? Thank you very much. So I definitely would like to congratulate Dr. Nikhil and the organizers for organizing this, especially for giving me a topic which was published in Lancet Ophthalmology on February 4th. So that is how hot and off the press is this topic. And then thank you very much for giving me this opportunity to learn and talk about it to everybody else. Next slide, please. Yeah, so basically this was published on February 4th in Lancet Oncology. I'm going to be talking about aromatase inhibitors versus tamoxifen in premenopausal women with estrogen receptor positive early stage breast cancer treated with ovarian suppression. This is a patient level meta-analysis of more than 7,000 women from 4 randomized trials. Next slide, please. So essentially, the background for this meta-analysis was that for women with hormone positive early breast cancer, adjuvant tamoxifen reduced the risk of dying from breast cancer within 15 years by about 30%. Aromatase inhibitors, when they came into the picture, they proved to be more effective than tamoxifen, but in postmenopausal women, reducing this risk by a further 30%. For premenopausal women, however, aromatase inhibitors has not been an option given the fact that there is residual ovarian function. So the aim of this meta-analysis was to investigate whether premenopausal women who received ovarian suppression as a part of their adjuvant hormonal therapy benefited from aromatase inhibitors over and above the use of tamoxifen. Next slide, please. So this meta-analysis included individual patient level data, and this comparing aromatase inhibitors versus tamoxifen for 3 or 5 years in ER-positive breast cancer patients receiving ovarian suppression. The ovarian suppression here was in the form of gossarin or triptorelin, or even ablation was also allowed, which is not such a common practice these days. So the primary outcomes of this meta-analysis were breast cancer recurrence, breast cancer mortality, death without recurrence, and all-cause mortality. Next slide, please. So 4 main trials which were chosen for this meta-analysis was the ABCSG12 trial, the ubiquitous soft and text data that we are all so happy to quote, the HOBOE trials also. So these 4 trials form the backbone of this meta-analysis. All put together, 7,030 women with ER-positive tumors were enrolled between June 1999 and August 2015. So there was a significant median follow-up of at least 8 years, and above all, this gives us enough time to see, if ER-positive patients did end up having a relapse. So the rate of breast cancer recurrence was lower for women allocated to aromatase inhibitor than for women assigned to tamoxifen. Here the relative risk was 0.79, and it was statistically significant. Next slide, please. Breast cancer recurrence was significantly reduced in the group who had received aromatase inhibitors instead of tamoxifen. Overall, the risk was reduced by an average of about 20%. The main benefit was seen in the first 5 years when the treatments differed, where the risk of recurrence was a third lower in the aromatase inhibitors group. So this is the only point probably which I want to highlight in my very short talk, is that the main benefit was in the initial 5 years only. So the concept of using one for 5 years and another agent for another 5 years was probably a part of a previous analysis. So the absolute risk reduction in the risk of recurrence was 3.2%. So women who went on premenopausal women who went on aromatase inhibitors had a 6.9% risk of recurrence, whereas women who went on the tamoxifen group had a 10.1% risk of recurrence. And these are again numbers which are quite better than our historically reported figures for premenopausal women. Next slide, please. There was no further benefit or loss of benefit between 5 to 10 years, which means that whatever interventions that we do decide, we would have to institute them in the first 5 years. Aromatase inhibitors were just as effective in women aged under 35 who have a higher risk of recurrence than older women. There was no apparent difference in the number of deaths from breast cancer or any other cause. However, survival benefits from AIs may become apparent after a longer period of follow-up. Next slide, please. One slide on the safety data. There was a slightly higher proportion of women in the AI group who had a bone issue as compared to tamoxifen, which was quite natural. However, the frequency of bone fractures was very low overall. AI group had about 6%, tamoxifen group had about 5%, and we know and we have routinely started to use bisphosphonates even in early breast cancer patients. The 5-year incidence of endometrial cancer was higher in the tamoxifen group, which was 0.3%, again quite insignificant as compared to aromatase inhibitors group, which was 0.2%, but still it was rare overall. Next slide, please. So I conclude my talk by giving out few of my own takeaways, and I'm quite certain that many of my own colleagues have switched to this practice. Using an AI rather than tamoxifen in premenopausal women receiving ovarian suppression does reduce the risk of breast cancer recurrence. Longer follow-up is needed to assess any impact on breast cancer mortality. Hopefully, this data should also be out in another 7-8 years. Effects on quality of life need to be considered as well, and even though bisphosphonate use is only once in 6 months in this setting, still women may not prefer this so much. AI aromatase inhibitors could increase the chance of a premenopausal woman remaining disease-free for longer compared to the traditional methods, allowing them to return to a normal life. Thank you for patient listening. I'm happy to take any questions.
Thank you so much, sir. Do we have any queries?
We'll have queries later, Dr. Firdaus. We'll move on to the next presentation.
Moving on, I invite Dr. Arun Chandrasekharan, Consultant Medical Oncologist, Aster, Calicut, to deliver his next talk. Welcome, sir.
Thank you. Can we have the slides on screen? Sorry, I'm traveling. Yeah. So thank you, Dr. Nikhil, for this opportunity. And today we just quickly go through the latest follow-up update of the text and the soft trials. It's actually the 13-year follow-up. And as we know, hormone receptive breast cancer does have a very long follow-up if you want to get proper results. So the what were these trials? They were basically designed to answer the question of whether the use of ovarian function suppression in addition to tamoxifen could improve survival, especially in patients who remain premenopausal after chemotherapy. So this question was asked by the soft trial. The other question was, which is better, tamoxifen or exemestane versus, in comparison to both of them in addition with OFS. And this was again the question which was raised by the text in the soft trial. And there was also the Perche trial, which looked to see whether you could omit chemotherapy altogether if you're using hormonal therapy with OFS. However, that trial closed early because of poor accrual. And we know that the soft and text results were positive. The addition of OFS to tamoxifen improved the recurrence-free survival as well as overall survival. When you compare aromatase inhibitor to tamoxifen, the difference in recurrence-free survival was there, but not in overall survival. Those with low-risk clinico-pathological features, they fared well with tamoxifen alone. And the current update looks at the data for the 13 years. Next slide. So this was the design of the text and the soft trial. This enrolled premenopausal hormone receptor positive patients, and they were randomized in the text trial to tamoxifen plus OFS versus exemestane plus OFS. They were given for a total of 5 years. And in the soft trial, the only difference was that the randomization of patients who received chemotherapy was done after the completed chemotherapy, provided they remained premenopausal. So those patients who became postmenopausal after chemotherapy were excluded from that. And there were 3 arms in this soft trial as well. Next slide. And the next one. So a total of 4,000 patients were there in a combination of both these trials. And this is the patient characteristics. As you can see, patients who were younger, less than 35 years of age, who were lymph node positive, who had a size of more than 2 centimeter, grade 3 HER2 positive, all these patients had an increased chance of receiving chemotherapy. These were basically the high-risk patients. And the only difference in the soft, as you can see in the bottom next slide, is the surgery to randomization was almost 8 months in the soft trial. So the randomization time was 8 months in the soft trial, whereas in all the other ones, it was somewhat similar. And this is the 13-year follow-up. So the first question is whether OFS addition was beneficial. And as you can see in the slide here, yes, the benefit or absolute benefit is around 1.4% when you use tamoxifen plus OFS, and the overall survival improvement is 2.3% at 12 years. And with the use of exemestane plus OFS, the improvement is 3% and overall survival is 2.6%, and this is clinically significant. Next slide. This is the question of which is better, tamoxifen or aromatase inhibitor. As you can see, there's a slight benefit of using exemestane, 1.8% with the recurrence-free interval. But if you look at the overall survival, it's a difference of 1%, but this was not statistically significant. So again, this confirms that aromatase inhibitors improve the recurrence-free survival, but not the overall survival. Next. Now looking at certain cohorts of the soft trial, the cohort which did not receive chemotherapy. In this cohort, you can see the survival with tamoxifen alone was more than 95%. So this tells us that in a good risk patient who does not require chemotherapy, you do not need to add OFS. You can just use tamoxifen alone. Next slide. This is the cohort, a combination of the soft and the text cohorts. And again, this was looking at the good risk population. Here again, more than 95% of the women were surviving at 12 years, and tamoxifen alone could give you very good survival rates. Next slide. So this is the more poorer risk or high risk population. And this is the population who received prior chemotherapy. Almost 57% were lymph node positive. And in this, the distant recurrence-free survival, as you can see with tamoxifen, was an improvement of 2.6%. With exemestane, the improvement is much higher of 4.4. Could you have the next slide? Is it audible? I think, yeah, okay. I hope I'm audible. Reception is...
Yes, sir. You have 1 minute left to conclude. Yes.
No, can you just shift the slide?
Yeah, it's shifted. It's shifted. Yeah. So this is the cohort of HER2 positive with who received chemotherapy, and this is the cohort that did the maximum benefit, who had the maximum benefit with exemestane, and that survival was 3.3%. Next slide. And these are the subgroups in the soft and the text trial who had the maximum benefit with aromatase inhibitor. These were patients who received neoadjuvant chemotherapy, who were younger, age less than 35, who had a node positivity more than 4 and tumor size more than 2 centimeters. So this is the population who has the maximum benefit with exemestane. Next slide. So the overall conclusion of the soft and the text follow-up at 13 years was very similar to what the data, the previous slide, please. It's very similar to the previous data. It concluded that there is an improvement in the recurrence-free survival. Can I have the previous slide? Yeah, is it audible? Okay, next slide, I'll just conclude. I think the reception here is quite bad. Next slide, can we go? Yeah, this is the conclusion, yeah. So the long-term follow-up showed that, both the the recurrence-free survival was improved with the addition of OFS and overall survival as well. And exemestane did exceptionally well in a subgroup which had a high risk profile, which was the patients which were receiving chemotherapy. So the final my take would be use exemestane with OFS in that kind of population, the younger size more than 2 centimeters with node positivity who you're going to give chemotherapy. The next question is whether to shift to 3 monthly versus monthly OFS, whether we could make life easier for our patients. Thank you. I think there was a lot of breaking up in between. Sorry for that. Thank you.
Thank you so much, sir. Now we move on to the panel discussion. I invite Dr. Bharat Rangarajan, Consultant Medical Oncologist, Powai Medical Center and Hospital, to moderate this session. I invite our panelists, Dr. Rakesh Pininti, Consultant Medical Oncologist, Basavatarkam Indo-American Hospital, Hyderabad, Dr. Stalin Chowdhury Bata, Consultant Medical Oncologist, NIMS, Hyderabad, and Dr. Ram Abhinav, Consultant Medical Oncologist, Powai Medical Center and Hospital, Coimbatore, to join us for the discussion. Welcome, sir.
Thank you. I hope I'm audible. Thanks to Nikhil, my close friend, for giving me this task today. I trust I'm audible.
Yeah, Bharat, go ahead.
Yes. Can I request Dr. Arun and Dr. Aditya, who presented the papers, to stay on with us for their expert because they know these two abstracts the best. I request both of them to just stay on with us. So I will start with a very simple case. This is just the starting point. We'll just take off from the case and then we'll see what the ramifications are. So we have a very, very young homemaker. Husband is earning around 35,000 per month, 2 children aged 4 and 9. N2 and clinical M0. She has a PET scan which shows no metastases. 4.5 centimeter lesion, 5 out of 16 lymph nodes positive. It is a grade 3 lesion, which is ER/PR positive, Ki67 20 to 25%, and HER2 is negative. She's completed 4 cycles of adjuvant with Dosden's AC and Dosden's Paclitaxel and followed by radiotherapy. She is G-BRCA negative. So with this, shall I ask my colleague, my friend, Dr. Ram, what would be, your first option for her in terms of adjuvant hormones?
I would consider the fourth option, AI with GnRH agonist for 5 years. And the other option is adding abemaciclib also.
Okay. And
to hormones.
To hormones. Excellent. Other panelists, Dr. Stalin, what would you opt for?
So my option also would be an AA with a GnRH agonist. But if she is not affordable for it because of the cost, definitely I may counsel for a laparoscopic.
I have actually, that's why I've put, how much the husband earns. She's a homemaker. They have 2 children.
Yeah, definitely laparoscopic BSO. I will counsel her regarding the pros and cons of it. If she is willing for it, she completed family. Definitely, I offer OFS in terms of oophorectomy.
Oophorectomy. And Dr. Rakesh?
I would actually offer her tamoxifen plus GnRH agonist for 2 to 3 years.
Tamoxifen plus, yes.
Tamoxifen plus GnRH agonist, because it is not very easy for everybody to tolerate AA plus GnRH agonist.
Absolutely,
so let's test her.
Doctor. Absolutely,
let's test her with some amount of tamoxifen, and tolerance is well. Then we can take it forward.
Take it forward. There is also another reason why we can use tamoxifen upfront. Dr. Arun presented the data on OFS. How convinced are you about OFS with tamoxifen versus OFS alone in this subgroup, Dr. Arun, after your presentation? I think Dr. Arun is not here. Dr. Aditya, he presented the other abstract. Is he here with us?
No, sir.
So our 2 presenters, are they with us?
I don't think so.
You don't think so? Fine. So then we'll go back to the panelists. Dr. Rakesh, excellent point regarding tamoxifen. I will also go back to Dr. Ram. If you're going to start AI with an OFS, what are the things that you think need to be counseled about, and what are the baseline monitoring that you should have done before you embark this? Dr. Ram Abhinav?
Yes, one thing is post chemotherapy still in premenopausal status. That is one point. And we'll have to counsel her about the long-term side effects, the effects of long-term estrogen depletion, the cost involved, the sexual life of the patient, how it will be altered. These are some things. And the long-term cardiac morbidity due to altered lipid. All these are the things I would counsel.
And any hormone levels or anything you would check before you start?
Yes, I will. That's what I said. I said every 3 months I would check E2 and FSH to make sure that she is maintaining the. First thing is we'll have to check whether she is in the premenopausal status post chemotherapy, and if she's still in the premenopausal status, then we'll have to check her every 3 months that she's maintaining pre or postmenopausal status with GnRH analogs.
And I think that comes to the point of what Dr. Rakesh Piniti also said. We may have to really check the E2 FSH levels and give them a few doses of GnRH analogs before they actually attain true hormonal menopause, and then maybe switch on to an AI if they can still tolerate after the trial of tamoxifen. Am I right, Dr. Rakesh?
Actually, if you look at text, there is a provision of using GnRH agonist along with the chemotherapy, concurrent with the chemotherapy.
Exactly. Text started earlier.
Yeah, if you can adopt that, then probably the issue of checking the E2 FSH will be much more lesser when they actually come to the conclusion of actually starting the tamoxifen versus AI.
Absolutely.
But even then, I would probably start with tamoxifen, even if you have already assumed that and proven that the patient is postmenopausal. Still, the adverse effects, the initial hot flushes, and the sexual dysfunction is much more adverse for a young lady at 31 years of age. So I wouldn't really push for a AA plus OFS right away. Probably tamoxifen plus OFS will give us enough time to understand how the patient reacts.
Which leads us to the next question. The primary endpoint is DFS. When you look at soft and text, the combined. So now we are dealing with the first question of question of OFS. So the question of OFS, the primary endpoint of the soft and text 8-year analysis was the DFS analysis. And Dr. Stalin, when you look at the DFS alone and the definition of DFS given in the trial, do you think that these points are really relevant for us to take on OFS with whatever benefit we get for as DFS, rather than take on the distant metastasis-free survival, as the Arun showed those slides to us, as the the real relevant or clinically meaningful endpoint in the clinic?
In the clinic, if you want to consider among the DFS and distant metastasis recurrence-free survival, definitely DMRF is a more robust endpoint, because DFS includes just the ipsilateral breast second primary or a contralateral breast recurrence also. Compared to the distant metastasis recurrence-free survival, DFS is not that robust endpoint to push such a toxic therapy into the clinical practice.
Absolutely, that is also one point that I did feel when I was going through the soft and text in detail. Dr. Ram, in your opinion, the distant metastasis-free survival was a secondary endpoint for the soft and text in the 8-year analysis, and in the current analysis also they have looked at the distant metastasis-free survival. So, in your clinic for a 31-year-old, how would you sort of take the local recurrence in the treated breast, a contralateral non-metastatic recurrence in the opposite breast, or a second cancer in some other site? How important are these when you're considering such a toxic therapy vis-a-vis actual breast cancer metastasis happening?
They are important, in my opinion. They are important. So a patient having recurrence itself is a poor prognostic factor, and it is not as toxic as it has been projected. There are side effects of ovarian function suppression, but it is with a modest benefit. There are two ways to achieve it with either tamoxifen or AI, but it is not very toxic in my opinion. And any form of recurrence is a poor prognostic factor, so it is important.
So form of recurrence in the form of in-breast recurrence or an opposite recurrence is also very important.
Yes.
And mandates use of
it
OFS.
is important.
Yeah, one point.
It is
Dr. Stalin, hello.
Yes.
Doctor, sir, when we compare both endpoints, DMRF is a robust indicator. But when you're explaining to the patients, so as Dr. Ram said, DFS is also a good endpoint, because if the patient had a contralateral breast recurrence or an ipsilateral second primary, it adds to the cost of the treatment, toxicity to the treatment, again receiving the chemotherapy, radiotherapy, and it impairs some quality of life also. So when counseling the patients, definitely DFS is also endpoint, but coming to comparing both, definitely distant metastasis recurrence-free survival is the more robust endpoint than the DFS alone.
And that was a secondary endpoint, and we looked at the DMFS is not really very significantly better. It's a little less than 2% benefit by even adding OFS to tamoxifen or AI. Now, Dr. Ram, so by this thing, almost everyone is a candidate for OFS, or is there anybody who is not a candidate for OFS? If you are selecting a patient, how would you select?
Sorry, I couldn't hear that in the middle. Sorry, can you repeat that?
So by DFS, you say is a most important endpoint. So by that, who are the candidates who you would say do not require OFS?
Probably the low risk patients who did not receive chemotherapy. Probably these are the patients who would not benefit from ovarian function suppression.
So who would you not give chemotherapy? So I mean, because this definition of low risk is a little dicey. ASCO has defined something in 2016. After that, we have not really seen a definition. So how would you define in the clinic tomorrow?
See, right now we are talking only about soft and text trials, but there are other two trials as well, which are comparing the tamoxifen, and there's one trial which is directly comparing AI and tamoxifen, and there is Astra trial which is comparing addition of 2 years of tamoxifen with tamoxifen plus ovarian suppression. So the conclusion is we'll have to take all factors into account when we come to a conclusion. So probably the patients whom you decide on giving hormones alone, probably these are the patients in clinical practice. That can be due to various factors. It can be with oncotype DX, or you based on either clinical characteristics, you decide this patient is only for hormonal therapy. So when you decide this patient is only for hormonal therapy, probably these are a set of patients who would not benefit from ovarian function suppression.
Got that. So
and those
whom you
patients
give
who you decide that you would benefit with chemotherapy would be the patients. But
would all
because
get OFS. Who would all get a OFS?
Yeah, correct.
Absolutely. Okay. Dr. Rakesh, so how would you, define the patient who's not going to take chemotherapy? Would the genomic risk factors come into play now? Soft and text have not actually used it for everybody. How would you, decide that this is the patient not for chemotherapy and hence not for OFS? And this is a patient who is for OFS, he is for chemotherapy and hence for OFS. So everybody for chemotherapy is also for OFS. So how would you use the genomic status also?
I would love to use
Rakesh.
the genomic for yes, sir. I would love to use the genomic for everyone, but that's not the practical situation now.
So what are the other things in the
other things?
Age,
yes,
how would you take?
Less than 35, probably definitely chemotherapy, irrespective of the T size being more than 2 centimeters or more than 1.5 centimeters also is fine. Node positive disease definitely will go for chemotherapy in my practice, and those are the patients who will be actually counseled for OFS. And primary size, I would say anybody more than 5 centimeters are surely for OFS and chemotherapy. This more than 1 centimeter, more than 2 centimeters, I'm not aware of the complete data set where exactly the 1 and 2 coming from, but definitely for anybody more than 4 centimeters or more than T2 size, definitely will go for chemotherapy and definitely will go for OFS.
So
again,
so Rakesh, let me just ask you this: a ball in another, let me put if it was a 61-year-old with a 2 centimeter lesion and one lymph node positive, she's ER strongly positive, PR strongly positive, low key 67, and low key 67 of say less than 10%. But she's N1 positive. She can't do a genomic risk. Would you give chemotherapy? Would you avoid chemotherapy? Would you give OFS? Would you avoid OFS here? There is no OFS here. Sorry. Oh, she's postmenopausal. So
I would probably look at the Ki-67. If it is less than 20%, I'd probably give only hormones.
Okay, so I will just leave you with this slide. There is a delta of around 2% for the entire cohort of soft and text, and although the hazards are good, if you look at the freedom from distant recurrence, as Dr. Stalin told us, the hazards are good, but the real delta is just around short of 2%. That is the difference that you will get in freedom from metastasis by using OFS. Either OFS with TAM or OFS with AI, whichever you use. It's the DFS difference is just around 2%, not DFS. Metastasis free recurrence is 2%, and you would get around 4 to 7% of DFS, depending on whether it was node positive or node negative. So I think the OFS question we will go on. This has been discussed. So time, I think already Rakesh answered. When would you start, Rakesh, for everybody along with chemotherapy or later on? What is the consensus and how long will you give it?
Everybody with chemotherapy for 2 years. I'll not go for 5 years. there is one Japanese trial that has tried to compare between 2 and 5 years, and there appears to be no major benefit between 2 and 5 years. Definitely 2 years is doable, practical. I think I'll stick to 2 years.
2 years of OFS. Dr. Ram, 2 years of OFS starting with chemotherapy or 5 years? Dr. Bala, 2 years of OFS or 5 years?
My practice is 5 years of OFS. Possibly, most of the times it is after the chemotherapy.
Okay. And how would you monitor during, OFS?
I would usually probably do a monthly GnRH agonist. So I would rather not do a regular E2FSH levels.
You would not.
And I would probably check for toxicity in the form of symptomatic arthralgias, myalgias, any interventions if required, including physiotherapy and other yoga techniques.
And bone health.
Yeah, bone mineral density at least once in a year will be done. And there will be an opportunity to include bisphosphonates or any other rank ligand to preserve the bone density.
Excellent.
Sir, sorry for intervening. You have 2 minutes to conclude.
Okay, so we will go to the second abstract which is presented, which is the question of AI versus tamoxifen. This is a meta-analysis of 4 different trials with 7030 patients. And but there are other meta-analysis, as Dr. Ram pointed out. This is not the only meta-analysis. So AI versus tamoxifen. So this is basically, Dr. Ram and Dr. Piniti, one chose AI and one chose tamoxifen. Now, I would ask Dr. Ram, why AI over tamoxifen? Is there so much of a benefit based on the trials? Actually, the OS seems to favor tamoxifen rather than AI, although the DFS favors AI. So why would you choose AI, especially the young woman with more toxicities?
Yes. So I'll make 3 points. One is, as we had discussed, monthly and 3-monthly GnRH agonists seem to be having equal potency. The 3-monthly GnRH agonists with 2 phase 3 trials are proven to be non-inferior to monthly GnRH agonists. And second point is, we can use tamoxifen or AI. There is a phase 3 trial which has shown overall survival benefit, and this trial only included patients post chemotherapy, only the high-risk patients, compared to the soft and text trial where only 50 to 60% of the patients had chemotherapy. And third point is, when we look at all the 4 trials, or actually 4 trials, when you look at all the 4 trials, the better regimen is AI plus OFS. The benefit seems to be very marginal over OFS plus tamoxifen. So it may not be relevant, but if you ask the best regimen,
the DFS benefit or the OS
DFS benefit.
OS benefit actually in the large meta-analysis seem to be favoring the tamoxifen rather than the AI.
No. So the one thing, if you look at the meta-analysis, the Astra trial was not included in the meta-analysis. So,
and the Astra trial,
so we cannot make a conclusion.
Coming to your point, Astra trial, how long was the GnRH administered in both the arms?
It was for 2 years.
It was a shorter OFS rather than a 5-year OS. Your choice was for a 5-year OFS, not for a 2 to 3 year OFS.
Now, if we have to use AI, the present recommendation would be to consider 5-year OFS. So if you're going with tamoxifen, probably we can cut short to 2 years.
If you're using tamoxifen.
Tamoxifen, as a scientific discussion. As Dr. Rakesh said, probably we can.
Okay, so what I wanted to bring out is there is a lot of heterogeneity in use duration of AI of OFS also 2 years, 3 years, and 5 years. And if you're comparing with 2 to 3 years versus 5 years and then continuing anastrozole, there can be a confounding factor there which we must remember. And I think we have actually covered all this. So if I were to summarize, I would say. It is a first step that gives the biggest benefit. So endocrine therapy per se gave a huge incremental benefit for breast cancer. But after the endocrine therapy, if you can compare tamoxifen versus AI in postmenopausal women, 2 to 3% benefit. And then if you compare tamoxifen for 5 years versus 10 years, maybe around 2 to 3% benefit. If you add OFS in younger women, again 2 to 3% benefit. So that magnitude of benefit always remains and comes at an added toxicity. the OS advantage with the AI has not been proven along with OFS. OS advantage seems to be similar for AI and tamoxifen when you're using 5 years of OFS. There is no overall survival advantage. Distant metastasis-free survival advantage seems to be fairly low, although the DFS seems to be good. And whether we should consider all tumors? No, we should be considering the high-risk tumors for whom we give chemotherapy. I think there is a consensus. Now, after this, I would ask all my panelists to, come back to our case and look at, the advantages, disadvantages, and give their final words. Dr. Stalin Bala.
So for this case, sir?
No, your general, on use of OFS and choice of agent, AI versus TAM with OFS. Your final.
So my choice of hormonal therapy is an AI plus OFS. That is a GNR Chenlog for 5 years. So most of the times. So that will be a monthly GNR Chenlog. So we'll explain the patient regarding the cost if she is not willing for it. So definitely a oophorectomy is an option in my practice. So, and how long the OFS? Definitely for 5 years is my practice, sir. And for whom? Definitely for those patients who are requiring chemotherapy.
Good. Dr. Ram?
My general practice is 2 years of OFS with tamoxifen. And that is only for patients who are high risk for recurrence and who receive chemotherapy. This is purely because the monitoring is easier and the chance of even there is a ovarian escape, you are safe because with AI, it will be risky to continue AI without complete ovarian suppression, only purely for that reason. But in an ideal scenario, OFS plus AI for 5 years would be the ideal choice.
What you do and what you would want to do are different from what I gather. Dr. Rakesh?
I think the one important snippet of information what we are getting from this update is that if the patient is not requiring chemotherapy, there are absolutely around 40% of total population of soft and text combined. They had more than 95% DFS at the end of 10 to 12 years.
Absolutely.
So there is a role for tamoxifen alone as well in this group of patients. I think we need to also realize that.
I think that was Nikhil rather. Yeah. So
Rakesh.
So I think I will conclude here. Excellent points made out by the panelists. Thank you very much. There are patients whom tamoxifen alone will work, especially the ones who do not need chemotherapy. And if you're using OFS, ideal would be 5 years of GNRH with AI, but the ideal may be difficult to manage in practice. So tamoxifen with a lower duration of OFS may be a practical middle path. That is the sort of message from the audience, no, message from the panelists. And before I end, I will just add my small thing. Most of my patients, including the high-risk patients who take chemotherapy, many of them are still on tamoxifen alone. I don't, use OFS for many patients. I do use OFS for some patients, but not for all. And that is basically based on, so many other factors, which, are toxicities, discussion with the patient, and cost, definitely. With that, I thank the panelists and the organizers and Dr. Nikhil for this opportunity. Thank you very much.
Thank you, sir.
Thank you so much, sir. Here we come to the end of the second session. I thank all the faculty members for a wonderful session. We move on to the third session regarding the role of genomic assays in hormone receptor positive early breast cancer. I request Dr. Shikhar Kumar, Consultant Medical Oncologist, Onco Cancer Center, Hyderabad, to deliver his talk. Welcome, sir.
Thank you, ma'am. And thank you, Dr. Nikhil, sir, and the organizers for giving me this opportunity. Can I share my slides?
Yes, sir, you can.
Can the slides be displayed? I'm having some difficulty in sharing them.
Ram,
Yes,
can
I
you
will
share
share.
the slides for the backend, please?
Yes, yes.
Okay. So this is the update of the RX Ponder trial. As we know, the results of RX Ponder were published last year in the NEJM in December. That was after I think 5.5 years of follow-up, and now after an additional few IDFS events, the update has been presented. Next slide. Next slide. So as we know, RX Ponder, after the publication of Taylor X, this study was undertaken to understand the role of this 21 gene oncotype DX score in hormone positive, HER2 negative breast cancer, but in women who had N1 disease, that is 1 to 3 positive lymph nodes. And here, what they initially published was that the benefit of chemotherapy differed according to menopausal status, which was a pre-specified analysis. They only took patients of a recurrence score of less than 25. And what they noted was that post-menopausal women, irrespective of their clinical risk factors, whether it was a T2 or T3, whether it was 2 or 3 positive nodes, or irrespective of grade, they did not benefit from chemotherapy at 5 years. And premenopausal women, chemotherapy benefit was observed. So in this update, the updates in the invasive disease-free survival and the distant relapse-free survival have been presented, and a new analysis of distant recurrence-free interval has also been presented. Next slide. So this is what we discussed. Women more than 18 years with hormone receptor positive disease, they were randomized to either chemoendocrine or only endocrine, and they were stratified as per the recurrence score 0 to 13 versus 14 to 25, their menopausal status, and the type of axillary surgery that they underwent. Next slide. And the IDFS and the distant relapse-free survival is what was presented initially, and distant recurrence-free interval is a new parameter that has been reported at present. And distant recurrence-free interval is basically, it excludes death from non-breast cancer related causes, whereas distant relapse-free survival includes death from non-breast cancer cases as well. Next slide. So even in the updated analysis with the additional events that have accrued so far, postmenopausal women do not seem to have any benefit with the addition of chemotherapy if they have a recurrence score between 0 to 25. As you can see, the IDFS curves as well as the DRFS curves are exactly on top of each other, and there is not even any difference in the different subgroups that have been analyzed. Next slide. Premenopausal women again continue to show benefit with chemotherapy, both in terms of IDFS as well as distant relapse-free survival. The 5-year distant relapse-free survival benefit has reduced marginally from 3.3% benefit to a 2.5% benefit, but it is still continues to be statistically significant. And the 5-year IDFS benefit continues to be the same, that is a absolute benefit of 4.9%. Next slide. This is the new analysis which was presented in this current update. That is the distant recurrence-free interval in which deaths from non-breast cancer related causes were excluded. And again, here also the similar pattern has emerged in which post-menopausal women have not benefited with the addition of chemotherapy, but premenopausal women continue to show benefit in here also, in which the 5-year DRFI absolute benefit of 2.5% has been noted. But there is not a significant difference in terms of whether the recurrence score was 0 to 13 or it was 14 to 25. So both groups benefited equally. Next slide. They did additional post hoc analysis in the subgroup of around the 30% women in this trial who were premenopausal. And they also analyzed the outcomes in women who had PN1 microscopic disease as well. Next slide. And what they showed that even in women who had PN1 microscopic disease also, premenopausal women, even though this was a smaller subgroup, but even this subgroup also benefited with the addition of chemotherapy with this particular risk score. And the absolute benefit, as you can see in the slides, was 7.3%. And as we know, anyhow, PN1 disease, the benefit was the same. That is the curve on the right is the same, but the curve on the left was the new analysis done in this update. Next slide. Now, what is to be understood is that ovarian function suppression at the time at which this trial had begun enrolling, OFS was still not routinely followed, and OFS rates were actually low. Only 19% of women in the endocrine alone arm received OFS, and even fewer women in the chemo endocrine arm, that is only 6% women received OFS. So this trial was not designed to answer the question that whether this benefit seen with chemotherapy in the premenopausal women, was it because of the direct chemotherapy effect, or was it because of the premature menopause induced by chemotherapy, that is chemo-induced amenorrhea. So this trial cannot answer the question as to whether OFS can replace the role of chemotherapy in this premenopausal subgroup. Next slide. And here again, there's which has been reported, there is no IDFS difference in premenopausal women if OFS was given or not, but this trial was not neither powered nor designed to answer this question. Next slide. And again, next slide. So like the NSA-BP 30 trial, which studied concurrent versus sequential taxanes after docetaxel and cyclophosphamide, in that trial also, the women who achieved amenorrhea after chemotherapy, they had a significantly better outcomes in terms of both DFS and OS, in which they had a hazard ratio of 0.7. And a similar pattern also has been observed in this study as well, in that women whose periods reduced after chemotherapy, those who achieved amenorrhea, they had better outcomes. Next slide. The same thing which I have explained, that can be seen, that those who stopped having regular periods in the first 24 months after treatment, they had better outcomes than those who continued to have their periods. Next slide. So the conclusions from this trial are that even at this current update, postmenopausal women with a recurrence score of 0 to 25, they do not benefit from the addition of adjuvant chemotherapy. And this is irrespective of clinical factors like the tumor size, the number of nodes, whether it was 2 or 3 nodes, the grade of the tumor, the common clinical factors that we take into consideration while considering adjuvant chemotherapy. But premenopausal women, they continue to benefit with the addition of chemotherapy to endocrine therapy. And unlike the Taylor X trial, which showed that the magnitude of benefit of chemotherapy was more in the risk score of 20 to 25 versus 16 to 20, this difference in magnitude of benefit was not observed in R-Exponder. And an exploratory analysis, as I have shown, even in microscopic disease, TN1 disease, even those women also continue to benefit with chemotherapy. Next slide. And as I said, this trial was neither designed nor powered to answer the question whether OFS can replace chemotherapy in premenopausal women, and if chemotherapy-induced amenorrhea is as good as ovarian function suppression-induced amenorrhea in long-term disease control, and a future study is necessary to answer this important clinical question. Next slide. Thank you. That's all.
Thank you, sir. Moving on, now we have, for the next session, for the next talk, I request Dr. Krishna Chaitanya, Consultant Medical Oncologist, MNJ Institute of Oncology, Hyderabad, to join us. Welcome, sir.
Yeah, thank you, Fidos. And thanks a lot, Nikhil, sir, for this opportunity. Let me share my screen. So I'm going to discuss about the update which was presented in SABCS this December, last December 2021. This was presented by Cynthia and colleagues. Is this a PAM50 intrinsic subtype and risk of recurrence score in the prediction of the endocrine sensitivity and the pathological response to chemotherapy in postmenopausal women who have a stage 2, stage 3 disease and hormone receptor positive or to negative breast cancer in the alternate trial design. So the usage of neoadjuvant endocrine therapy will definitely gives us an opportunity to assess the endocrine therapy sensitivity, and they have defined the intrinsic endocrine therapy resistance as presence of these high Ki67 and biopsy after 4 weeks of neoadjuvant endocrine therapy usage. Or a sensitivity of endocrine therapy is defined as having a PCR or MPP of 0 at the end of endocrine therapy, that is 6 months before surgery. That is the usage of endocrine therapy 6 months and then followed by surgery. At the surgery, if you have a PCR or MPP 0, they have considered as endocrine sensitive. We know that the PAM50 risk of recurrence score with intrinsic subtypes by tumor RNA profiling is a prognostic marker for early stage hormone receptor positive in predicting the PCR rates for chemotherapy. They have hypothesized that these PAM50 analysis can be also used to assess this endocrine sensitivity or resistance by assessing the endocrine resistance as who has a high Ki67 after 4 weeks of endocrine therapy, or having a PCR or MPP 0 at the time of surgery, or assessing the PCR for who have received the neoadjuvant chemotherapy who are not responding to endocrine therapy at 4 weeks. So this is the alternate study design. The eligible patients were the postmenopausal having a stage 2 or stage 3 disease, endocrine receptor positive, all red scores of 6 to 8, HER2 negative breast cancer. They have been randomized 3 arms, either a single agent anastrozole, fulvestrant, or a combination. After the usage of 4 weeks of endocrine therapy, if the Ki67 is more than 10%, they were offered neoadjuvant chemotherapy rather than continuation of endocrine therapy. The others were continued endocrine therapy for 6 months and they have undergone surgery. At the surgery, if they have a MPP score of 0, that means they have endocrine sensitive disease and no adjuvant chemotherapy was offered, and they were put on adjuvant endocrine therapy without any adjuvant chemo. If there is a MPP non-zero cases, they were offered both chemotherapy and the adjuvant endocrine therapy. So this study was done to predict the PAM50 intrinsic subtype and the risk of recurrence score values. Can they predict this endocrine sensitivity or resistance? So in the total trial, 749 patients were enrolled. The remaining were not enrolled because of they couldn't do this RNA sequencing in them. And what the study population includes, most of them are luminal A and luminal B tumors, and 7% of them were non-luminal. Even though they had a very high endocrine receptor like all-red score 6 to 8, but 7 to 8% were non-luminal cases. And when you see this grading of the tumor, the luminal A and luminal B had a major cases of grade 1 and grade 2 tumors rather than grade 3. And non-luminal, all of them are not grade 3, only 2/3 were grade 3 and 1/3 were grade 1 and grade 2. Similarly, the Ki67 values at the baseline, they were very high for the luminal A and the luminal B as expected, and it was equally evenly distributed for the non-luminal subtypes. This study, they could assess that the PAM50 subtype, the luminal subtypes, luminal A, B, and the non-luminal, at 4 weeks of endocrine therapy, at the biopsy done after 4 weeks of endocrine therapy, they could see that the non-luminal type, that 70% of them were endocrine resistant. And this was like statistically significant between the subtypes. You could see that 13% of the luminal A had a endocrine resistance and 32% of the luminal B, but 70% of the non-luminal cases had endocrine resistance. And whoever like endocrine sensitive and continued endocrine therapy, at the end of surgery, they could assess that 25% of them had a PCR or MPP 0. That is like complete endocrine sensitive, and they didn't need any adjuvant chemotherapy. And this was like statistically significant between these luminal subtypes. And as well, when you take this risk of recurrence score, the risk stratification, low, intermediate, and the high grade, here also there is a significant difference between the 3 arms, the endocrine resistant disease or the how they respond with only endocrine therapy. And the cases where they could predict that endocrine resistance is there, they were like offered chemotherapy. In them also, this PAM50 score and the intrinsic subtypes and the risk stratification clearly mentioned that the luminal A subtype that can't achieve the PCR rates it was like 0 cases achieved the PCR rates, and the low risk, low ROR category also couldn't attain any kind of PCR. Whereas the HER2 enriched disease had achieved 20% of the PCRs, and the high ROR cases had a good PCR compared to others. So this study, to conclude, the PAM50 and the PAM50 intrinsic subtypes and the recurrence score, they could definitely predict the endocrine sensitive and the resistant disease in these hormone receptor positive postmenopausal patients. And the non-luminal subtypes were observed in 7% of this alternate trial, despite the high ER expression at diagnosis. And non-luminal tumors were not uniformly high grade. You would see that 2/3 of them are high grade and remaining were low grade. And Ki67, more than 10% at week 4, which defines the endocrine resistance. And there is a significant difference between the PAM50 intrinsic subtypes and the risk categories. And non-luminal subtype are a high risk score, were more likely to have an early endocrine resistance, or they can't achieve this MPP 0 score, indicating that they are resistant to neoadjuvant endocrine therapy. And for the patients who have triaged to neoadjuvant chemotherapy based on the early high Ki67, HER2 enriched group had a highest PCR rate, and no PCRs were seen in the luminal A tumors. This data suggests the PAM50 intrinsic subtypes could be used to guide the neoadjuvant treatment decisions in postmenopausal patients in hormone receptor positive and HER2 negative breast cancer. This study is a very promising study, utilizing this PAM50 intrinsic subtypes or the recurrent risk score in predicting the endocrine sensitivity. It will be definitely useful in the clinical practice, and whoever is not fit enough for the chemotherapy, or where you suspect that the chemo won't work in them, definitely this score would guide us in choosing the neoadjuvant therapies, either endocrine therapy or chemotherapy. With this, I would like to end the talk. So thanks once again for the opportunity, Nikhil sir.
Thank you so much, sir. Moving on for the next talk, I invite Dr. Harish Kancharla, Consultant Medical Oncologist and Hemato-Oncologist, Yashoda Hospital, Hyderabad, to deliver his abstract. Welcome, sir.
Thank you so much, Nikhil sir, and organizers for giving this opportunity. Can I have my slides? So this phase 3 randomized trial has looked into the role of metformin in preventing the recurrence and improving the survival in early stage breast cancer. Next slide. So these are all basically the concept of repurposing of the drugs, those drugs which are used in the other medical conditions to be had to show any role in the cancer therapy. Those kind of drugs like metformin, which is a commonly used anti-diabetic drug, and azoles, like in basal cell carcinoma and clarithromycin multiple myeloma. So this metformin has been selected for the study because this has been shown and observed in the retrospective studies and observational studies that it has shown to have weight loss and lower insulin levels and reduce the growth of the cancer cells, especially breast cancer studies in the market. There was emerging events evidence that its use has given associated with the better breast cancer outcomes, and it has strengthened the rationale for the study. Next slide. And current studies' primary objectives were invasive disease-free survival, basically between the subjects who are treated with metformin and who are treated with the standard chemotherapy along with placebo. And the secondary endpoints of the studies were overall survival and distant disease-free survival, breast cancer-free interval, and breast cancer-specific mortality. In this study, they also studied the other apart from advanced event, they also studied the health-related quality of life and the trial-specific symptom checklist. Along with that, they have done frequent blood monitoring to check for the levels of cancer tumor markers. And another correlative analysis they done in the first subset of HER2 positive disease were a genetic analysis of the DNA for the specific single nucleotide polymorphism to see the role of metformin metabolism and its sensitive role, as in seen with the other studies of insulin, lowering of insulin with metformin, and how they are sensitive to the drug. Next slide. So this is a multicentric double-blinded placebo-controlled study, which was conducted with the coordination of CCTG, Canadian Cancer Trial Group, along with under the umbrella of British, under the umbrella of Breast International Group, where they've included all the patients from UK, Switzerland, and Canada. And around they have recruited around 3,600 patients who are of early invasive breast cancer patients who are diagnosed within 1 year of biopsy or surgery, and who have disease T1 to T3, T1C, especially T1C, and T3, and N0 to N0. They have excluded T4 diseases, and they have also taken those patients who have received standard chemotherapy, adjuvant chemotherapy or not, and they have excluded those patients who have congestive cardiac failure, liver and kidney failure, which increases acidosis in the blood level. So, and other patients who have already have recurrence and presented with metastatic disease. So they have randomized in 1:1 fashion into metformin investigation group, and along with the placebo, along with the standard chemotherapy. And they stratified based on their hormone positive status and bone marrow, the body mass index, and HER2 positive or not negative, and whether they have received a chemo or not. In the investigation arm, they have given metformin 850 mg twice daily for 5 years, and in the first 1 month, they have given 4 weeks, they have given only single dose dosing, and they ramped up to BD dosing subsequently from 2nd month onwards. And they have followed for every 6 monthly with blood samples of fasting sugars and tumor marker levels, and they have been followed for another 60 months from the trial of investigation. Next. So this trial was enrollment was started in August 2010, where the target of the recruitment was 3,500 patients, just to achieve the adequate power of 80%. They expected 431 events after follow-up of 5 years. And in the 2016, there was second interim analysis was done for especially those patients who are ERPR negative, irrespective of the HER2 status. There was found it was futile, so continue the metformin in the trial investigation arm, and there's just continued blinding, but stop with intervention. And they have continued the intervention in out of ER positive patients. And this current update, which was currently published, which included those patients with ER positive, and they just observed the subgroup analysis of this HER2 positive disease. Next slide. So they, in the study, this primary analysis was primarily focused on hormone positive breast cancer patient regardless of the HER2 status, and they have done the follow-up of those patients with the hormone negative. Though it was proved to futile at the interim analysis, they just continue to follow with the double blinding. And they have done an exploratory analysis of HER2 positive disease with single nucleotide polymorphism in the specific locus of RS, which is close to the ATMG, which I've discussed subsequently. Next slide.
Sorry for intervening. You have 2 minutes to conclude, please.
Yeah. So, in the hormone positive population, around 70% of the population, that's 2,500. The baseline characteristics like clinical characteristics and pathological characteristics and treatment assigned were comparable. Next slide. So there was no difference in the non-hematological toxicity with respect to the metformin drug, that is special lactic acidosis and macrocytic anemias. And though there were clinically higher than assigned investigation group, it was not statistically significant. Next slide. So the primary objective of the study was invasive disease-free survival. Out of 75.6% of events were occurred, and it was shown that there was no difference in the distant recurrence and local regional recurrences. And next slide. The IDFS rates were comparable with around 234 events in the metformin arm and 231 in the placebo arm. It was similar, and there was no statistical difference between the IDFS with the investigation arm and the comparator arm. Next slide. As a case with the overall survival as well, secondary objective, there was no difference in the events of in the either metformin or placebo arm. Next slide. So Other secondary objects were like distant disease survival and breast cancer free interval and invasive breast cancer free survival. Both are similar in between the in between the metformin and placebo groups in the hormone positive subjects. Next slide. With this analysis, it was concluded that metformin should not be used as a breast cancer treatment in this population, hormone positive population, after along with the standard chemotherapy, as there was no difference in the DFS, IDFS, and OS and other breast cancer outcomes. Next slide. So other follow-up, next slide. Other follow-up fertility results, follow-up of the fertility result patients with hormone negative breast cancer patient were also seen the similar results as seen in the interim analysis. Like there was no difference in the IDFS and OS even after 96 months of follow-up with 245 events in the both subgroups, both arms. Next slide. So the same conclusion as in the hormone positive breast cancer patient, even hormone negative patients also. Metformin should not be used as a breast cancer treatment along with the standard chemotherapy, and it was hoped that it has an anti-cancer properties. But based on this phase 3 trial, it was clearly shown that it has no benefit in terms of IDFS or OS in the both hormone positive and hormone negative subjects. Next slide. Next slide. So there are around 600 subgroup of HER2 positive patients who are there, and they were stratified based on their whether they have a specific single nuclear polymorphism in terms of 112. This was a enhancer locus, which is close to the ATM gene, which was associated with improved metformin sensitivity. So it was in the previous trial, like a 24-week neoadjuvant study, where they have seen that clearly shown that there was those patients with specific this minor CLL were found to have significantly higher PCR, almost like 18%, and added advantage those who received metformin and having this CLL in this specific SNP. Next slide. Those same in the same hypothesis, the same results were observed in this phase 3 study as well. Those patients with around HER2 positive disease, those who received metformin have clear IDFS advantage compared to the placebo, and there's a clear benefit of overall survival as well. But next slide. So when they have stratified based on their SNP minor allele, that is CA or CC, there was a clear benefit to those patients who have this minor allele CC in this single nuclear polymorphism, but there's no benefit in those patients who have major allele, that is AA, with single nucleotide polymorphism. And in fact, they have has a detrimental effect when have used the metformin in these patients, specific subgroup of patients with HER2 status. Next slide. So in this next slide. So it has concluded that those patients with minor CLL single SNP with this particular locus close to the ATM has increased sensitivity to metformin and per se, and those patients with HER2 positive had clear IDFS and OS benefit, and increased PCR in the along with the neoadjuvant chemotherapy along with trastuzumab. But this trial was not pre-specified for these findings. They have done over time with observational data which was observed prior to the start of the study. So it was not powered enough to conclude that those patients with particular allele have benefit with the metformin. So this has to be confirmed with pragmatically formed phase 3 studies in the future. Definitely it is hypothesis generating, and we can those patients who have this particular allele with the minor allele, say population that comprises around 20 to 30% of all the population altogether, but varies between the ethnicity. And definitely it is a hypothesis generating study, can be confirmed in the future studies with prospective fashion. Next slide. It was concluded that metformin does not improve any disease survival or OS in terms of breast cancer outcomes in unselected this hormone positive and hormone negative breast cancer patient, and definitely should not be used unless until it's a clinical trial. And on those patients who have this HER2 positive disease and specific allele with this single nucleotide polymorphism and a minor allele formation, like 26% of the population can be taken up further study with the trastuzumab drug along with the metformin. Thank you.
Thank you, sir. Moving on, we'll be having a panel discussion regarding the abstracts discussed now. I invite Dr. Amit Ratan, Consultant Medical Oncologist, Manipal Hospital, Bangalore, to moderate the panel discussion. I invite our panelists, Dr. Rakesh Reddy, Consultant Medical Oncologist, Mahatma Gandhi Cancer Hospital, Visakhapatnam, Dr. Prasad Narayan, Senior Consultant Medical Oncologist, Site Cancer Center, Bangalore, Dr. Vijay Agarwal, Senior Consultant Medical Oncologist, Aster Hospital, Bangalore, to join us for the discussion. Welcome, sir.
Good evening, everyone. Thank you very much. I thank Dr. Nikhil for giving me this opportunity. So in the next 20 minutes, we'll quickly discuss these three abstracts. They've been presented very nicely. So first is RxPonder. So this is a very, probably the most important abstract where a lot of discussion can be done. So let's start off. So genomic testing, we've discussed this even in the last panel. How do we use it in practice? So let's start, Prasad, what patients do you send for genomic signature testing as of now in clinical practice?
So this is in early breast cancer, hormone positive, where you want to avoid chemotherapy. Specific question, right?
Right. I'm talking of, yes.
So,
correct.
Right. So not much actually in my practice yet. And if I'm asking somebody, I mean, mostly it is Oncotype DX.
Okay. And when you're asking somebody for Oncotype DX, which patients?
So in node positive patients, I have not asked for it Oncotype DX yet. So it is like the patients where you want to, you have a T3 lesion, which is like a, strong ERPR positive postmenopausal lady. Mostly I go with the phenotypic risk. If the phenotypic risk is high, I don't send for a genomic signature. But sometimes patients are getting a genomic signature or asking for that. That is that is more than me suggesting actually.
Okay, right. So you go more by the clinical data and clinical judgment call and then take it further, except in certain rare patients.
Sure.
Right. Okay. Vijay, what do you do? Which patients do you ask for testing and which tests?
Yeah, so essentially, people who have very low risk, so less than 2 centimeters or T2N0 lesions with low KS67, I just don't give chemotherapy. So I think that's the easy bit, that people who are already clinically low risk, I don't recommend testing to decide on whether to give chemo or not. People at a higher risk, so N2 disease plus, again, I don't ask for genomic testing because they all need chemotherapy. So you have these group of patients who are 2 to 5 centimeters, maybe grade 2, maybe 1 node positive, and they want to avoid chemotherapy. So what we're trying to do is identify those low risks people among the intermediate risks, among the clinically intermediate risk, but those low risk who can avoid chemotherapy. So genomic signatures. Now, I don't do a lot of this. We go predominantly by the clinical science and discussions with the patients. But if I do ask, it's usually an Oncotype or an EndoPredict. One of these two is what I tend to use.
Okay, so it's Oncotype and EndoPredict, and most of your clinical judgment is what you're talking about, but there are patients you would choose. Almost similar what Prasad was talking about. Right. And you're talking of any difference in the postmenopausal or premenopausal?
Oh, so it's all postmenopausal. It's all postmenopausal.
All postmenopausal, right.
Premenopausal, I rarely ask for genomic signatures. Sorry.
Right. So it's all postmenopausal. Right. Yeah. Right. Dr. Rakesh, your thoughts on how you use genomic signature currently in practice?
Yeah. So I agree with what the previous two panelists have said, and it won't change the next Monday also. I will still go by clinical judgment only because, cost is the major deterrent, obviously. And so obviously the factors that we are going to consider is the clinical factors of the tumor, like the T stage. So anything beyond T3 and anything beyond N2 is directly patients go for chemotherapy, or mostly if they can tolerate chemotherapy. It's those less than T3 and less than N2, then the question comes. And this is especially, I think, if I have to ask for, it would be in the postmenopausal women who fall into this categories, those who are less than T3 and those who are less than N2, where I would like to see if at all the patient is willing and is affordable. And yeah, again, the test that I use mostly, I used rather the CAN-assist breast by Oncostem and Oncotype DX, obviously because of the cost factor, I haven't used much. It's only in very few patients I can hold most of my fingers free. That is the situation. So it is mostly clinical yet. And if at all I have to use, I think the utility will be more for postmenopausal, whom we would want to use in N1 and T1, T2 disease.
Right. So kind of all of the panelists are kind of talking in the same way, and will probably take a clinical judgment for most of the postmenopausal women, and would try to get away without testing. The only problem comes in is that occasional patient that we think is low risk, and then you do a genetic signature and it comes surprisingly as high risk. And that's, though it's pretty rare, but I would say it happens sometimes. But again, we always discuss pros and cons, and that's the way we are doing it. So all postmenopausal women ideally should have a genomic signature if you are trying to avoid chemo. That's the ideal if we would talk about absolutely surety that can we avoid chemo. But all of us are taking clinical judgment calls, and I think we are right most of the times. I wouldn't say we are right all the times, but we are right most of the times when we try and avoid this chemotherapy. What about this? Let me just, Dr. Shikhar presented very elegantly the whole RxPonder. Dr. Shikhar, what are your thoughts on the pros and cons of genomic testing? I just put it to you. What are the pros and what are the cons, do you think?
Sir, nothing more to add from my side. I think all the panelists, I agree with all the panelists that this test is not going to really be helpful in premenopausal women, because despite whatever score they have, there is a clear-cut benefit, whether it was N0 in the TAILORx or N1 in the RxPonder. But yes, for the occasional postmenopausal women who have an intermediate risk disease and we want to avoid chemotherapy, this test will help you have a more nuanced and a balanced discussion with the patient regarding the advantages and the pros and cons of giving the patient a course of toxic chemotherapy for the next 3 to 4 months. But in my clinical practice so far, I have not used this scoring.
Okay, right. So that's right. So you emphatically said it, premenopausal, it's not going to benefit. I kind of keep thinking, so we are quite sure premenopausal now after this RxPonder that we are going to give chemo, so we don't require the test. Postmenopausal, we are taking a judgment call. Eventually, will there be space of these kind of testing in India? That's getting a little bit complicated when you try to choose these tests. Anyway, let's move on to thoughts about RxPonder study itself. So how are you going to interpret this data, Dr. Prasad?
I think when I see this data, there's a mature data which has come. It is not adding much more value in the postmenopausal setting. In the premenopausal, maybe that small percentage of the patients about the ovarian suppression, I think it is important. We don't know whether the premenopausal versus postmenopausal, that difference is because of the ovarian suppression or not. And in that study, 18% is I think the percentage of patients who got ovarian function suppression. And if you hear the previous moderation by Dr. Bharat, actually, in that also the panelists also said that in practice, ovarian function suppression is not very commonly practiced. Maybe, I don't know whether there will be a trial in this question, whether ovarian function suppression will make a premenopausal patient also behave like a postmenopausal, and we can avoid chemotherapy in those patients. I think that is the key question to answer, because as you rightly said, 90% of the time the clinical judgment will decide and will take, or it is that 10% of the patient. If we can avoid chemotherapy in a premenopausal patient, and it is the premenopausal patients who are looking to avoid chemotherapy, not the postmenopausal ones. The premenopausal patients are concerned about so many things. Many of them unmarried patient coming with a small breast cancer. You are saying that no, because you are premenopausal, you have to get chemotherapy. That is where if you have something like a temporary ovarian suppression, which can make a difference, that is where it's going to make a difference actually.
Right. So I think that's exactly where we want that space, but we are not going to get an answer. This percentage of patients with ovarian function suppression was too small in this trial to really answer this question, and I don't think I don't think this will really answer this question. So we'll have to eventually go by, again, back to clinical judgment. So let me just ask this question, because this is what bothers me. Now, which adjuvant chemo would you use? So my thought is like this: if you're not testing, okay, you get a postmenopausal T3N0 M0, you're not testing, you're taking a clinical judgment. What adjuvant chemo will you give? Vijay?
Yeah, so I think this is a clinical situation we face on a day-to-day basis, and I think it's an important question to discuss, to decide what to do on Monday. But realistically, there are essentially two chemo regimes: your AC-Pacli and its variations, and your T-Cyclo and its variations. And essentially, you choose from one of the two. There is no head-to-head comparison between AC-Pacli and variations versus T-Cyclo. I don't think so. I mean, we have this in our head at some level, having discussed in previous meetings, that AC-Pacli is more aggressive, more intensive, and better than T-Cyclo, but we don't have evidence for that. And when we're talking about T-Cyclo, we don't know, we're talking about 4 to 6 cycles. So essentially, a lot of this is you look at the patient and saying, not for AC-Pacli, maybe T-Cyclo, and then you take a pick.
So I'll put it to you: T3N0 M0 postmenopausal. What's your choice then?
T-Cyclo.
Okay. TC.
Sorry? Yeah,
so you're talking of TC, right? That's great.
Yeah.
And now, so the same patient you tested and it came out high risk. Will that change your chemo?
No, it would still be T-Cyclo.
Okay. And 4 cycles is enough?
And no, I would push to 6.
Okay.
So what I tell the patients is, when I discuss is 4 to 6 cycles, let's see how we go on. If they are struggling with neuropathy or neutropenia, then I might stop at 4, but I tend to push for 6.
Okay.
Particularly if the risk comes as high risk.
Right. So Dr. Rakesh, your thoughts on the same question? What would you do, P3? N0?
Okay. So taking into consideration all Dr. Vijay has already said, I would make it simple. So node positive, I would give AC-Pacli, and if node negative, I would go for DC.
And would it change if you got a high risk suddenly in the testing?
No, it wouldn't. If it is a node positive and found to be high risk, and if I want to give chemotherapy and the patient can tolerate anthracycline, then I would give AC and paclitaxel. If it is a node negative and high risk, I would give 4-TC.
Okay, so high risk, you would still stick to 4-TC. Okay, right.
Yeah, high risk and node negative. If it is,
yes.
I mean, node positive and found to be high risk, and I am giving chemotherapy at that particular juncture, if it is node negative, I would still go for 4-DC.
Right. Prasad, you same way?
Yeah, I agree. Yeah.
Right. Okay. So my sometimes that debate which comes to the mind is, if I was not testing, 4-TC becomes my standard for my postmenopausal woman, and I just do 4-TC without bothering about it much at all. But when it suddenly comes with a high score, then I think, I upstaged this patient for more than 4-TC, and that bothers me sometimes. That we would have got away with 4-TC. Now we test it and we'll have to give 6 cycles or something. So that sometimes it happens in clinical practice. Premenopausal, any difference, any change if you get a score and a high score? Is it the same thing, or TC, or would you not give TC and just give anthrax for all patients?
So this high risk, the high score is only to say that you need chemotherapy, right? It does not. It's not to decide on what chemotherapy to do. It doesn't change my chemotherapy choice.
Okay, so you're happy with 4-TC even your
right?
Okay, right. So this is I think this is where the space gets very kind of interesting to discuss, because everyone has their own options. But anyway, I think even in the trial we saw that there was a good number of patients with anthraxanes, and there were a good number of patients with TC. So whatever we do, nothing's wrong. It's just that we have to choose the chemo. What about hormonal in premenopausal? Bharat discussed this a lot and quite extensively and nicely. So that was a very interesting debate to listen to, a discussion to listen to in the premenopausal. Will it change if you're testing versus not testing? Vijay?
No, it won't change.
No difference?
No difference. I mean, I would try to give AIs to as many as possible. Premenopausal ovarian suppression is what I tend to use for anything that is T3 or N1 plus.
Okay, so AI, that means you have to give LHRH and 5 years of LHRH. Okay. So that was anyway.
So I'm actually a strong proponent of bilateral oophorectomy if the family is complete at the time of breast surgery.
Right, makes sense. I think definitely. Okay, so I think we had a good discussion about RxPonder. So I think the takeaway message of RxPonder. So there was one point here that N1 MIC that surprised me. You know, that data really surprised me. I was always thinking N1 MICs you can take as N0s and skip them sometimes, and that's what you were tempted in clinical practice. Rakesh, your thoughts now for N1 MIC? You were always for chemo for these patients?
Yeah, always was for chemo because I don't know. Even before this particular trial has come, even I think what you said, I agree. The absolute benefit did surprise me, though the number of events, if you see, it is 100 versus 100 here and 700 versus 700 in the N1. So the numbers were small and the number of events were small, very low. So probably that would explain the the divergent hazards, but still I think this is a good point. This is something that is at least a good signal to consider N1 microscopic is also significant. Now, I always had the hunch that it would be, but I always have been giving chemotherapy for these particular patients, especially premenopausal. But this is like a validation of the clinical practice rather.
Right. I agree with this because so it is a good validation. Now N1 MIC for us means better to give the chemo. We have enough data to say it's beneficial. Okay, so I think that was from RxPonder. The message we will get is premenopausal patients probably don't do the scoring at all. It doesn't make sense to do it because you would have a chemo benefit to all your patients. So premenopausal, there's really no need to do the testing. We have to definitely treat with chemo. Postmenopausal is the space where we do it. In India, we use a lot of clinical judgment and do it, but internationally, if you really want to say emphatically you don't want chemo, you should do one of the recurrence scores, prove it that the patient is low risk, and then avoid chemo is what the international experts talk about. So moving on to this next, the PAM50 presentation, I think Dr. Krishna did a very good job of it. I found this a very, very complicated presentation. It was so difficult to read. So Krishna actually made it very easy and straightforward to understand. And so this was the conclusion the authors wrote. This was the last line they wrote. It should be used as a guide for neoadjuvant in postmenopausal women. What do you say? Yes, no, Vijay?
I think there has to be a third choice. I don't know. See, this thing, it's an excellent study, very well presented. I think going forward, I think we have to start individualizing even the concept of neoadjuvant chemo, whom to give, whom not to give. Currently, neoadjuvant hormone therapy is not standard. So I think a lot of us, certainly for me, I'm not very comfortable with just neoadjuvant hormone therapy, irrespective of what the PAM50 shows. But I think if there is more data that comes out, or corroborative data to substantiate the same thing, that we could be safe by having a similar survival benefit, because we're talking about curative setting, and we do need to start looking at overall survival benefits for a lot of these studies. So I think I'm going to wait for some more data. I'm not sure on Monday I'm going to go and say do a PAM50 and then start some hormone and then decide on neoadjuvant chemo. So the answer is I don't know. I'm not going to change practice based on this study at this point in time, but I'm sure in due course I will be persuaded to do so.
Right. Okay. So you have tempted to looking at this data. Which patients do you usually give neoadjuvant hormone therapy, Prasad?
Actually, I don't give too much of neoadjuvant hormone therapy. Sometimes what happens is that when I have seen people doing neoadjuvant hormone therapy, and when the response happens, suddenly the patient starts getting everything. Then after the response, there is chemotherapy, there is radiation, and everything happens as if it would have happened if we had given the chemotherapy first. So I have not seen a clean only hormone therapy by even surgeons I have seen putting patients on hormone therapy initially. But once the surgery is done, and then suddenly there is a question of whether we should not give adjuvant treatment here actually. So, but this study actually, if you are thinking about starting a neoadjuvant hormone therapy, this may be helpful, because I don't think in practice we are going to do a 4 weeks biopsy and just depend on the Ki-67 to decide on a 16 weeks PAT-CR prediction. And the hard endpoints were not used here. I mean, we can't say that because we are going to predict the PAT CRs and the whatever score was used, we are not going to say that we can avoid using chemotherapy in this group of patients. That is my take actually. So a need study of neoadjuvant hormone versus neoadjuvant chemo, I don't think will happen also.
Right, right. So I understand what you're telling, and this happens in practice. Sometimes you end up getting four months or 6 months of neoadjuvant hormonal. You get downstaging, you get surgery done, very good surgery, and then you find 4-5 nodes are positive, and then you are referred for chemotherapy. So you end up saying, oh, you wanted to avoid this, and this you're back in this situation. Right. So I agree fully with you. This is what happens in clinical practice sometimes. Dr. Rakesh, do you give neoadjuvant hormonal in your patients, or you're talking the same way as what Prasad has been telling us? And
going back to your earlier question, I think this is a very nice and conceptually good study, but I think clinically finding the relevance for this particular study is very, very difficult, especially in the current scenario that we are in. Because obviously neoadjuvant hormonal therapy, when have we given? I think if the patient is the candidate for surgery, he will go for surgery. If the patient is not a candidate for surgery, a candidate for neoadjuvant therapy, it is always has been chemotherapy. And only if the patient is not a candidate for chemotherapy, then also we would go for surgery and then do adjuvant hormonal therapy. Doing a neoadjuvant hormonal therapy is in those probably a very locally advanced, a very large tumor mass that precludes our good surgery, and probably the margins will not be good, or matted lymph nodes in axillary this thing, and we will end up giving 4 to 6 months of hormonal therapy if they are not suitable for chemotherapy, to give chemotherapy. So this kind of scenario is pretty rare. It will be in those elderly age groups who want to avoid chemotherapy. So rather a good study from my point of view is what Dr. Prasad was saying, doing a neoadjuvant hormonal therapy versus neoadjuvant chemotherapy, and having an upfront genomic signature which would predict equally good response for both of the settings. Like PAM50 high risk, we know that it is not going to respond well with neoadjuvant hormonal therapy. So excluding that, the intermediate or low risk, and then stratify it versus neoadjuvant hormonal therapy versus chemotherapy, where we understand that probably chemotherapy is not going to be too much over beneficial over hormonal therapy. So probably if some sort of study is being done, then this genomic signature will have clinical implication. Otherwise, I don't see any clinical implication over here.
Right, right.
So sorry for intervening. You have 1 minute left to conclude.
Oh, okay. So I think quickly. We kind of, all of us have that consensus. There's really not much role of a genomic signature as of now in the neoadjuvant setting. If you're doing it, we're going to take a clinical judgment and do it in the postmenopausal woman, and watch after 4 to 6 months, and then take the decision of surgery. Incidentally, there is a study of comparison of chemo versus neoadjuvant hormonal, small numbers, but clearly said neoadjuvant hormonal is good enough. It gives you almost the same rates as what neoadjuvant chemo gave in your postmenopausal woman. But of course, this is only not with genomic signatures. So I think in future we'll have better studies, as already mentioned, that will include genomic signatures. So I think a quick word about the negative study. Metformin use, we've been talking about this so often for so many years. Metformin is an easy drug. Let's add it together to all our patients and do it. So I think it lays it to rest. What do you think? Any thoughts on this, Prasad?
I think there's no more, this question need not be addressed now.
Yeah.
But HER2 positive, the breast cancer also, I think that is just by chance actually. I don't think that is going to be explored in a big way, and that it is worth exploring also.
Correct. But I think it's good they did this big study with big numbers, because this is a question which used to come in practice so many times, many years ago. You say in every cancer, just add metformin, you'll have better responses. And we had so many negative data sets, but because none was a big good trial, we always said, oh, maybe it would help. It's such an easy thing to do. And I've seen people do it also some years back. But a good study which clearly says that we should not be doing it. And I think Dr. Harish presented the data very well, nicely. With this, I thank all the members for very good discussion, telling us about where we will be applying these in practice in future. And with this, I thank everyone, and back to the organizers. Thank you.
Thank you so much, sir. I thank all the faculty members for their wonderful session. Moving on, we'll be having Dr. Monica Bopanna, Consultant Medical Oncologist, KIMS Hospital, Hyderabad, to deliver her talk. Welcome, ma'am.
Yeah, hi. Can you hear me?
Yes, ma'am, you're audible.
Yeah, and I hope you can see my screen.
Yes, ma'am.
Yeah. A very good evening, everyone. First of all, I would like to thank the organizers and Dr. Nikhil for giving me this opportunity to present this important abstract of taxane with anthracycline versus taxane without anthracycline, a patient-level meta-analysis that was conducted by the EBCTCG. So we know that anthracycline and taxane containing chemotherapy regimens reduce the risk of breast cancer recurrence by about 1/3 as compared to no chemotherapy alone. But both these classes of drugs have their own unique toxicities. The cardiovascular risk and leukemia risk associated with anthracyclines, these are much graver toxicities as compared to the neuropathy of taxanes. And it's the concerns about this anthracycline-induced cardiotoxicity or leukemia that has made the non-anthracycline-based regimens much more popular, especially the taxane-based regimens like docetaxel cyclophosphamide. That's the TC regimen, which is being increasingly used these days. The benefits and risks of this approach have been assessed in several RCTs, but with conflicting results. And hence, this study was taken up to better characterize the benefits and risks of anthracyclines and taxane chemotherapy for early breast cancer. This was an individual patient-level meta-analysis of data from 16 randomized control trials, including 18,000 odd patients, and the trials were all trials that were started before the year 2010. All the trials included at least 6 cycles of chemotherapy in each arm. The primary outcomes were recurrences, the time to invasive breast cancer recurrence, to be more specific. The recurrence could be a distant recurrence, a locoregional recurrence, or a new contralateral breast primary, and cause-specific breast cancer mortality, which were analyzed by the standard EBCTCG methods. The trials which were included in the meta-analysis, they were divided into 4 groups. Group A consisted of 3 trials that had 6 cycles of concurrent anthracycline plus docetaxel plus cyclophosphamide versus 6 cycles of the same dose docetaxel plus cyclophosphamide. Group B included 8 trials which analyzed sequential anthracycline taxane, which is the most common regimen that's used in our regular clinical practice, versus higher cumulative dose docetaxel plus cyclophosphamide. Group C included 3 trials of taxane plus anthracycline versus higher cumulative dose of taxane with or without capecitabine. And Group D included 2 trials of taxane plus anthracycline versus higher cumulative dose of taxane plus carboplatin. So that's a total of 16 trials. If you look at the primary outcomes, overall, patients who were treated with an anthracycline taxane combination, they had a 15% lower rate of breast cancer recurrence with a risk ratio of 0.85 and a 10-year gain of 2.5%, which was statistically significant, absolute reduction of about 2.5% in the 10-year recurrence rate. And with respect to breast cancer mortality, the 10-year risk of death from breast cancer was decreased by 1.6%, which was also statistically significant. And the important thing here is that there was no increase in deaths without recurrence. So the non-breast cancer related mortality, it was not higher in the anthracycline treated patients. If you look at this forest plot, the proportional reduction in recurrence was greatest in the trials that used concurrent anthracycline with docetaxel cyclophosphamide as compared to docetaxel alone. So here the difference between the 2 arms was only the presence or absence of anthracycline. By contrast, in trials that use the sequential regimen of anthracycline taxanes versus the higher dose, cumulative dose of taxane, because 6 DC were used here, there was no significant benefit from anthracyclines. But overall, if you see, anthracyclines did make a difference. The balance tips in favor of anthracycline-based chemotherapy. And if you look at the Group A and Group B alone, individual patient data were provided for all the patients in these 11 trials, which were included under these 2 groups, about 13,855 patients. And the median follow-up was 5.3 years. ER positivity was slightly higher in the Group B trials, and node positivity was slightly higher in Group A trials. HER2 positivity was almost the same. The cumulative dose of doxorubicin was 300 mg per meter square in group A. The cumulative dose of docetaxel in group A, both the arms was the same, 450 versus 450. And in group B, the cumulative dose of epirubicin was 300. But the difference lies here that in the sequential arm, where only 4 taxane-based cycles were included, the cumulative dose of docetaxel was 300, whereas when 6 DC were used, the cumulative dose of docetaxel was 450. And if you look at the, when you compare group A and group B, the breast cancer recurrence risk in group A, there's a 8.7% reduction in the 10-year recurrence rate when concurrent anthracycline was used as compared to DC. And in group B, where sequential anthracycline followed by taxane was compared with a 6 DC, that's a higher cumulative dose of taxane, there was no significant 10-year gain, just a 0.6% difference. And even for the breast cancer mortality, there is a 4.2% 10-year gain when anthracyclines were used concurrently, that is in group A. Whereas in group B, with the sequential use, the 10-year mortality was not different. And in the subgroup analysis, if you just take the group A trials, when the subgroups like ER positivity, node positivity, when they were assessed, there was a similar and a highly significant proportional reduction in recurrence in both ER negative and ER positive tumors. ER negative tumors showing a greater benefit. Whereas the relative risk for recurrence did not differ significantly for the other subgroups, including the nodal status. So irrespective of the nodal status, the anthracyclines did show benefit across all the nodal groups, right from N0 to N4 and above, or even node unknown. The combined analysis shows that there's no statistically significant difference in death without recurrence, no difference in deaths from cardiovascular disease or leukemia, but we know that a longer follow-up is required for this because we know that anthracycline-induced cardiotoxicity or leukemia sometimes can occur decades after receiving anthracycline also. Individual patient-level data on quality of life and toxicity were not available for this particular meta-analysis. So to conclude, all the trials when analyzed together in this meta-analysis, there was a 15% reduction and a 2.5% absolute reduction at 10 years in the risk of invasive recurrence for anthracycline plus taxanes versus taxane chemotherapy. Much larger proportional reduction of 42% was seen with concurrent schedules where anthracycline was used along with DC with the same dose of taxane in both the arms. Little, if any, benefit in trials of sequential anthracycline and taxane versus higher dose taxane in the control group, and proportional reduction in recurrence did not differ by the ER status or the nodal status. So my take on this is that if we really have to realize the benefits of anthracyclines over and above those of TC alone, we probably have to give anthracycline concurrently with TC, that's giving all the 3 drugs together, which may be associated with a slightly higher risk of hematological and other toxicities, which might be more in our population. And if we have to avoid anthracyclines altogether, then 6 TC would be the way to go. So have we reached a point where we can completely do away without anthracyclines for breast cancer? Probably not. I would still give anthracyclines, and I would try to avoid them only in those patients in whom there is a higher risk of cardiac toxicity, and in them 6 cycles of docetaxel cyclophosphamide is probably the best regimen. Thank you very much.
Thank you so much, ma'am. With this, we conclude our 3rd session. Moving on to the next session, we have it is sponsored by AstraZeneca. I invite Dr. Bharat Vaswani, Senior Consultant Medical Oncologist and Hematologist, Yashoda Hospital, Hyderabad, to deliver the next talk. Welcome, sir.
Good evening. Thanks, Nikhil, for a kind invitation. Let me thank Astra for giving me a chance. Let me thank them again for actually allowing me to change some of the slides, because probably I wanted to present some good things, so they allowed me to present what I wanted to. So my slides are visible, and am I audible?
Yes, sir, you're audible, sir.
So the topic that I am discussing in the next 15 minutes that has been given to me by Nikhil is redefining the management of HER2 negative early breast cancer in the era of precision medicine. So a triple negative and a ER/PR positive HER2 negative, what's new? So the key question that I'm trying to answer in the next 10-15 minutes is, what are the novel molecules that have been introduced in the treatment of early stage HER2/neu negative breast cancer? Or in other words, what is new in the management of HER2/neu negative early breast cancer? And the most important thing, have these improved the outcome by giving these drugs? So let me start by answering my first question. Now, what is new in the management of HER2/neu negative breast cancer? And that is what? So we have the following things are new. Now, when we talk about it, let us differentiate ourselves with triple negative and hormone receptor positive. Now, in the 1 year, we have 3 pivotal studies. I think so probably the management of early HER2/neu negative or a triple negative have probably changed, or we have really cleared some of the confusion that we have. These are the role of immuno-oncology drugs. Has carboplatin really found its place in the neoadjuvant setting? The answer is yes now. And the sponsor has presentation olaparib in the adjuvant setting. Probably, I think so. This is also here to stay. For a HER2/neu, for a hormone receptor positive, I'll be discussing the pivotal study which has got FDA approval. That is a monarchy. Now, when we talk about triple negative, probably a high risk subset, the previous speaker has already spoken. But the most important thing to remember is you need to give your anthracycline and taxanes both in the treatment of triple negative. Of course, the quantum of benefit changes, but even in node negative, you have a 2.5% IDFS benefit, and it goes on increasing as the stage of the disease increases. And probably from a T2 onwards, all patients should be given a neoadjuvant chemotherapy, helps in de-escalation of surgery, and more importantly, for risk stratification based on presence of residual disease or not. So let me start my first study, which was a keynote 522 study. Please remember doxorubicin and endoxin, surgery, and then another 9 cycles. So the total of 1 year. Now, when you look into the primary endpoint, the primary endpoint was pathological CR and a event-free survival. These were the main endpoint, and I think both these endpoints were satisfied, and there was a statistical difference. A 13.6% increase in pathological CR, and those with a PD-L1 positive, the pathological CR went still 68%. Now, when you look into the other endpoint, and probably this was the most important thing which we have been discussing for the last 6 months, at 2 years follow-up, there was no statistically significant improvement in event-free survival. But at 3 years, that difference becomes statistically significant. So around 7.5 to 8% absolute benefit in event-free survival with a 37% reduction in the risk of progression, what you can say. So this was a positive study. More importantly, you have 65 to 70% of the patient who you are getting to a pathological CR just by adding an immuno-oncology drug. And this is by far the best pathological CR that we have achieved in a triple negative subset. When you look into the subset analysis, all the subsets, irrespective of the stage, menopause stages, LDH benefited. So this is a drug for all, not based on any subset. All good things have a bad thing, and I will like you to be more careful about this. A higher incidence of infusion-related reaction, hypothyroidism, skin reaction, hyperthyroidism, adrenal insufficiency. But the most important thing is nearly 1 in 4 patients had discontinued treatment. So again, there is always that doubt that probably in early breast cancer, probably are these patients less tolerant to immuno-oncology drugs. So although a very good study, improvement in everything, but yes, this is a toxic regimen. Even people, the sponsors also told that some side effects are lifelong. So a bit careful when you give this in the early breast cancer. Now, this is a nutshell thing that you need to remember. 4 pivotal studies, and now we are having 2 studies which show that event-free survival is improved, and 1 study till now, that is GEPAR-NEO, which was a durvalumab study, had shown the improvement in OS also, but that was a phase 2 study. So all in all, first take-home message, immune checkpoint inhibitors to be added to chemotherapy has led to improvement in pathological CR, all the 4 studies, and 2 studies after 4 has shown that there is an improvement in event-free survival, and early results suggest, as per as GEPAR-NEO, there is maybe an improvement in OS also. So a big yes from my side. The second study, and probably now this debate is solved, is do you really require a carboplatin in a neoadjuvant setting? Basically, this trial had looked into PARP inhibitor veliparib along with carbopacli or a single agent paclitaxel. So, if you see, the primary endpoint was pathological CR, and the secondary endpoint was event-free survival, overall survival, and safety. And probably the important thing is early analysis had shown pathological CR improvement, but this analysis shows that event-free survival is also improved. And we have 2 studies now out of 3 which has shown the improvement, and probably that is a way to go. Now try to look into the boxes that have nearly 25 to 27% improvement in the patient who achieved a pathological CR. So from 31% to 58%. But the icing on the cake is on the right side. From 68.5% event-free survival, you have 79.3%. And this was statistically significant. In fact, there was some improvement in OS numerically, but it was not statistically significant. So around 20 to 25% improvement in pathological CR, but more importantly, more than 10% improvement in event-free survival. 3 studies till now. If you give only platinum, without platinum, if you say AC followed by taxane, 35% pathological CR. Now, if you see in all the 3 studies, one thing is constant. There is an improvement in pathological CR, and the improvement is of the order of 20%. But what is more heartening is, out of the 3, except for American studies, the German and this study shows that there is a statistically significant improvement in event-free survival also. So second take-home message should be carboplatin. I think I am more confident in. I am always using it in my high-risk triple negative, but yes, carboplatin should be added to chemotherapy in neoadjuvant setting as it improves pathological CR, and now 2 studies out of 3 shows that there is improvement in event-free survival. Now let me come to the sponsor side. What about BRCA mutation? I think so. This is also one of the best studies and one of the practice-changing studies. Around 5% incidence in breast cancer, of course, 20% in triple negative, and lesser in the hormone receptor positive. Now, when you look into Indian data, probably they say that the number is more. But again, all of us know that most of us don't test this BRCA testing in the early breast cancer. But it is high time that we start doing it, not as a preventive aspect, but as a treatment aspect also. We know that BRCA mutant cancers are diagnosed at younger age, higher burden, more metastatic state, more contralateral, and a higher chance of recurrence. So all in all, a high risk cancer when you have a BRCA mutation positive. So coming to Olympia, this is adjuvant. When you talk about Olympia, so you add a D and it becomes a metastatic. Germline BRCA mutation positive, stage 2 to 3. Please remember, these were high risk patients, not in like a Keynote 522, which had some early breast cancer patients also. Around 50% had taken neoadjuvant followed by surgery, and around 48% had given adjuvant and then given olaparib. So it was a olaparib versus placebo. Please remember, the primary endpoint was IDFS, and the secondary endpoint was distance and overall survival. How did they divide among it? So if it is early stage breast cancer so if you don't achieve your pathological CR, it is high risk, and for hormone receptor positive based on your the clinical and the ERPR receptor state. The most important thing, 85.9 with a 8.8 absolute improvement versus placebo, 42% reduction in the risk of IDFS. So probably this quantum of benefit is very good. Now, when you look into subgroup analysis, again, all the subgroup, even if you have taken your platins in the neoadjuvant, this drug can be given in the adjuvant, post-adjuvant setting because there was an improvement. Similarly, in all the mutation, whether in adjuvant or neoadjuvant, both, whenever you give this drug, there is improvement. When you look into distance, again, that quantum of benefit remains more or less the same, 7 to 8% and a 43% reduction in the distance recurrence. Now, again, when you talk about overall survival, this benefit is 3.7, probably just 1.05 if you look into a higher limit. So you have a data which shows that you have a 8% is quite a big number, improvement in IDFS, around 7 to 8% in distance recurrence. Now, we are all worried about toxicities of PARP inhibitor, but when you look into the toxicities, I have underlined it, only 9.9% discontinuation. So 1 in 10 patients only discontinue due to toxicity, grade 3 or more, 1 in 4, serious adverse event, again 1 in 10. And these are all expected, that is hematological, and a fatigue. So probably in early setting or probably given earlier, this toxicity profile looks far better than what we have seen in the ovarian cancer. Now come to quality of life. So again, earlier deterioration, but over a period of time, if you see the curve has come together, so not much deterioration in the quality of life. In fact, there is the quality of life is more or less maintained. And when you look into the other parameters, again, initial, there is a gap, but over a period of time, the curves are together. So probably all in all, a drug where the quality of life is more or less maintained over a longer period of time, and more so once you have stopped the drug. Now, all the debate that is what I wanted to present. Why not to give a capecitabine? Why to give a olaparib? Because if you remember your strata of what we say Createx and this Japanese studies, all the studies show that there is an improvement in your DFS around 8 to 10% and your OS also around 8 to 10%. I'll go back also for the studies. So both the studies more or less shows that if you have not achieved your pathological CR, you should give capecitabine, or you can still give your capecitabine post your adjuvant treatment as per as the Chinese study. But my point of contention is PARP inhibitors are more potent than capecitabine. Do we have a data to support it? The answer is yes. That is extrapolating from your Olympiad study, which was a metastatic study. In an Olympiad study, the other arm contained capecitabine in 45% of the patients. And we all know there was a statistically significant improvement in PFS when olaparib was compared with capecitabine. So probably based on that data, we know that this is good, and you have a germline mutation and you have a better data available. So why not use it? Again, there is no head-on comparison and everybody has their own opinion, but definitely as per the data in the metastatic setting, olaparib is supposed to be more potent than capecitabine. The last part of my presentation. What about hormone receptor positive? So there were 2-3 pivotal studies, if you say, based on the early use of CDK4/6 inhibitor. The first question comes, why do we need a CDK4/6 inhibitor in the adjuvant setting? So the answer is approximately 30% of patients diagnosed with early hormone positive HER2 negative have a risk of recurrence. Now, difficult to say which are these patients, but when we say it is multiple node positive or a larger size tumor, high grade tumor with a high Ki67, probably these were the ways they were tested. So let me come to the first study, Monarch E study. 2 years of abemaciclib in a high risk patient. The high risk, I think so, is good. So more than 4 nodes positive or 1, 2, 3 with any of the 3 factors. So either a T3, grade 3 or a Ki67 more than 20. 2 years of abemaciclib versus a study. And the primary endpoint was IDFS. Now, when you look into the first analysis that was done in last year ESMO, there was a benefit, around 3% benefit with around 29% reduction in the risk of the recurrence. And when you look into the distance recurrence, the quantum of benefit around 3% remains the same. Now, what was heartening was the updated analysis shows that this quantum of benefit is in fact more. So now this difference from 3 has increased to 5.4%. So 88.8 versus 83.3. In fact, so what you see is once the drug has been stopped and when you have seen over a period of time, so it is 1 year that we have stopped the drug, but yes, the quantum of benefit remains the same or more, and it continues to show the response. So the first positive trial and probably the only positive trial apart from hormonal, which shows a really good benefit in giving a CDK4/6 inhibitor for 2 years. But remember, abemaciclib. Again, a drug which is slightly toxic, but I would like you to remember that only 17% of the patients discontinued abemaciclib. This was the one difference that was there in PALA study of PALVO, where more than 40% discontinued treatment. So more of the patient took this drug for 2 years. The toxicities which are manageable, including diarrhea and hematological, and more importantly, the bad toxicity, that is thromboembolism or ILD, they were lesser. The last 2 slides. What about PALAS study? So PALAS and Penelope, both were negative studies. And the main reason, you don't know the reason, but according to me, probably the population taken. If you look into PALAS study, N2 disease was in 30 to 40, whereas in case of Monarch study, it was in 58 to 60%. And probably according to me, abema is slightly more potent in terms of CDK9 inhibition and probably a lesser toxic drug because only 17% discontinued the abema and versus for more than 40% in palbociclib. So both the studies were negative. Even in a longer follow-up that has been presented, there is no no improvement. So one drug for now in the adjuvant setting in hormone positive, which is abemaciclib, based on the impressive data of monarchy. So I have told you about 4 studies: Keynote study, Brightness study, Olympia study, and last but not the least, this is a abemaciclib monarchy study. So if I have to summarize my presentation, what's new in early stage HER2 negative breast cancer? So recent developments has led us to understand a lot of subtypes of this. So you need to treat your triple negative breast cancer differently for how hormone receptor positive is. The most exciting data is with germline BRCA1, BRCA2 mutation, a drug with a very impressive response, around 8 to 9% absolute improvement. That is the Olympiad study, less than 10% discontinuation. And other data, including Keynote data 522, you had a JPAS data, shows that immune oncology drugs are here to stay even in the neoadjuvant setting, and abemaciclib, that is a CDK4/6 inhibitor in the early hormone receptor positive carcinoma breast. But the last line, which is the most important line, is let us understand the role of these agents in the light of existing therapies allows us to optimize the treatment studies in a way that we can achieve the best outcome from the agent. So I always say a right drug at the right time in a right patient will always give you an excellent response. I thank Nikhil for a kind invitation and allowing me to speak my slide. Thank you, Nikhil.
Thank you, Bharat.
Thank you so much.
Yeah.
Thanks.
Yeah. So, Bharat, there was one question for you, whether we can combine immunotherapy with olaparib. You want to take it quickly?
Yeah. Now, in the metastatic setting, there are 2 studies that have been done. There is no study till now, Mediola study and that. So probably a concept which will be which is getting explored. So probably we don't have much data in the neoadjuvant setting. Yes, in metastatic, we have 2 studies till now, which has shown some improvement, not the way we expected. But as far as now, the data doesn't suggest that this drugs can be given in a phase 3 setting. But yes, an exciting concept which is evolving. Metastatic, we have a data, neoadjuvant, the data is there. There are a few studies going on regarding this.
All right. Thank you so much, Bharat. I think it's always wonderful to listen to you. And you have done an exceedingly good job by covering quite different aspects of the breast cancer. And I must congratulate you for that. And I think we are coming to the conclusion of the day 1 of the event. We again have tomorrow, day 2, starting at 5:30 p.m. in the evening. This event has been organized through Aegis of Cancer Research and Statistics Foundation in association with Yashoda Hospital. I would like to thank all the faculty members, moderators, as well as the speakers for giving their excellent insights. We have some very interesting debate coming up tomorrow. I request all of you to be there for that. We had quite a significant participation from the, I would say, from various delegates from various parts of the country also. So looking forward to all of you for tomorrow evening again, sharp at 5:30 p.m. And with this, I conclude today's evening, and I wish you all a very good night and see you tomorrow at 5:30 p.m. Thank you.
Yeah.